Eu não sei se tu ouviu, por ser psicológico. Posso ajudar alguma coisa?
Tá, tô.
Ah, né? Tipo, Ah,
Sim. Sim. Bom, vamos começar. Bom dia a todos. O meu nome é António Vaz Carneiro, eu sou presidente do Instituto de Saúde Baseado na Evidência da Faculdade de Medicina e de Farmácia da Universidade de Lisboa e sou um dos responsáveis pela organização desta reunião, juntamente com a Millions Missing, que é a Associação de Doentes, como sabem. I will now switch to English because I was asked to do so. And I'm very happy just to introduce myself. I'm António Vaz Carneiro. I'm a physician and a clinical researcher, and I'm the head of an Institute for Evidence-Based Healthcare at University of Lisbon School of Medicine. I'm also the director of Cochrane Portugal. And the reason why I'm here is because patients reach out for me because they know that I work a lot with, my center works a lot with patients. And about 2.5 years ago, Joan called me up and said, I need your help. And I'm not expert on long COVID or ME or nothing. I'm just your regular clinical internist. But once we met and we started discussing this thing together, it became obvious that we had a huge problem in our hands. And the problem is that now, at that time was even worse than now, nobody would recognize that there was this post-viral type of syndromes in which the patients would acquire a whole bunch of symptoms that because we didn't have a pathognomonic approach to it, there was not a specific imaging or blood test to diagnose it, nobody would believe them. So suddenly all along came COVID first, and then came long COVID. And that changed the entire landscape of the field. And now we are having what we really need, which is money to do research. Because without money, we don't have research. So from our standpoint of view, we start working on maybe just, starting at the beginning, speaking with people, increasing awareness of this disease, talking with all stakeholders, physicians, health administrators and managers, politicians, patients, and etc. And so we went through, and we decided to do the first international meeting on long COVID, ME, and CFS last year. We got so much luck, and it was so interesting and such a success, we decided to do it again this year. So it is with a lot of pleasure that I welcome here in Porto to our Medical Association building. And just a quick housekeeping. The lunch will be outside. People will tell you where it is. The bathrooms are over there. And basically, what's going to happen is we'll have blocks that are managed by specific people, and I'll introduce them, okay? So, once again, without any further ado, I would like to call to the floor Dr. Torres da Costa, which is the head of our medical association here in the North, and the person that actually runs the place here. So, Tor.
Muito bons dias aos presentes. Queria cumprimentar-vos a todos. And now in English, I would like to give my welcome to you all. I am Torres da Costa. I am responsible for these installations for the next 4 years. And for me, it's an honor to welcome you and to accept this meeting with some scientific team that is intriguing for me, because my health of labor is immune deficiency diseases. So I have some kind of cross-match with you, and I have some kind of difficulty to understand what it is normal, because I don't know if normal really exists. We have only variations of normal, and I think that many things that we are looking are some kind of those ways of presenting response to the environment, to virus, to bacteria, etc. So I welcome you, and I wish you a very pleasant sessions here. Thank you very much.
alguns que estão acamados, que não podem estar aqui hoje, que estão online, e um grupo também que está aqui trabalhando conosco, o Fernando, o André, alguns membros novos que esperemos integrar. So Aliança Millions Missing is a collective made up of, now an association made up of people that are living with this illness and caretakers and allies, like Dr. Vascarneiro, like Dr. Wink, like Dr. Nuno Sepúlveda, like Dr. Luis Nacol, like Dr. Ileana Lacerda, Dr. Sistrom, and the fabulous Joanna Squires that helped us in the conception of this conference and the previous one. So welcome, really welcome, and anything that you need from us, please let us know. Obrigada.
Thank you. Before I give the floor to Jaime Branco, Professor Jaime Branco, which is a clinician, is a full professor at Nova Medical School, and is a rheumatologist. Before I give him the floor, I kept our thanks to the speakers. Thank you very much, guys. It is really, really appreciated that you come from such a faraway distance to be here with us. We are very grateful, and we hope that we can repeat this thing several times in the next coming years. Is that okay? Okay, great. So without further ado, I will call now Professor Jaime Branco to the floor. I'm sorry. I will call to the floor the Nuno Sepúlveda for his intervention called Epidemiology of CFS and Long COVID. Okay, Nuno? The floor is yours. Nuno is an assistant professor of biostatistics and clinical trials of the Faculty of Mathematics and Information Science in Warsaw University in Technology. He is a long-standing collaborator with CEAUL, Center for Statistics and its Application at the University of Lisbon. He currently leads the biometrical section of the Portuguese Statistical Society, and in recent years he received funding from the British charity ME Research UK and Polish National Agency for Academic Exchange to study the role of antiviral antibodies on pathogenesis of ME and chronic fatigue syndrome. He also represents Portugal in the European network Euromine, where he integrated its executive board and in the working group dedicated to the study of ME, CFS, epidemiology all around Europe. So without further ado, Nuno, thank you very much for accepting our invitation. The floor is yours.
Thank you, Antonio. And I would like you to say good morning, everybody. And first of all, I think I have to say the same words that Antonio said. First of all, I would like to thank Joanna and her team, first of all, for organizing this wonderful event. It's a lot of effort. And of course, for inviting me to be here and share my knowledge on epidemiology of ME/CFS and long COVID. Like Antonio said, I'm a little bit like an outlier here. I'm a mathematician by training, and but I did my PhD in biomedical sciences in University of Porto. So it's nice to be back in Porto and see the city again. All right, so let's go to the science. And so today I'm going to talk about ME/CFS and long COVID. Mostly I'm going to focus on ME/CFS, and I will explain you why at the end. And mostly what I'm going to share with you is my experience as a biostatistician. So what's my perspective of the epidemiological data that is out there in literature, okay? So the outline, like I said, I just put it, just a brief introduction on the basic epidemiological concepts, so for the guys to understand what I'm telling you on some of the slides. I'm going to then to give you some information about epidemiology of ME/CFS and long COVID. And unfortunately, if I have time, I'll give you something about Portugal and on ME/CFS and long COVID, but only if I have time. If I don't have time, come to me if you really want to know a little bit more about Portugal, okay? So when we talk about epidemiology, there's like three words that come into my mind. So it's first of all, is prevalence, incidence, and risk factors, okay? So this is mostly what I'm going to talk about. Prevalence, it's a statistical concept, and it's a statistical concept associated with these questions. How many cases exist in a population at a given time point, okay? Incidence is another one, is actually a statistical concept related to a question is when actually you want to know how many new cases were generated per unit of time. And when I say unit of time in ME/CFS, mostly we are interested in new cases per year, okay? In the context of infectious diseases, on like outbreaks, actually sometimes it's per day, incidents per day. And the last one, the risk factors, it's related to which prior conditions predisposed to the disease onset. So, okay, so it's just to have everyone on the same wavelength. So we are going to talk about mostly about these three concepts. And I also want to bring you this, this last slide on the basic concept of epidemiology, because I think this is missing from most of the literature. So when we're talking about epidemiological surveillance of any disease, we have two arms for this surveillance. One is we call passive, which is mostly the cases that you can pick up in the national health systems. So it's on the concept of official health records. And then you have the second arm that is actually on the active side, and is mostly you going to the population, you're trying to pick up the cases actively. So you do what we call survey-based studies. So let's go to epidemiology of ME/CFS. Just a quick note on the disease diagnosis. I know this is a conference specialized on this disease, but no matter what, it's better to just to put this note out there. There's no biomarker, okay? And all the diagnosis is made on is based on a clinical diagnosis. And what we actually most for example, in the European Network for Chronic Fatigue Syndrome, the Ordem, we discussed what will be the most consensual case definitions for diagnosis. So we have like three criteria: 94 Cities for Disease Control criteria, which is called Fukuda or CDC criteria, the 2003 Canadian Consensus criteria, and then the 2015 Institute of Medicine criteria, okay? So when you actually analyze data, you need to know which diagnostic criteria you're talking about, because they are not exactly the same, okay? What we're going to, just to put some, more details on the criteria, this 1994 is the most well-known case definition of ME/CFS, and is mostly unexplained fatigue persisting for more than 6 months, and you have to have at least 4 out of 8 core symptoms. And I put it here there. The first one is post-exertion malaise. That in the beginning, in the definition of this, of this criteria, you have this post-exertion malaise was optional, but nowadays is actually the Ordem considered as an obligatory symptom. Okay. So then you have tender lymph nodes, muscle pain, unrefreshing sleep, new headaches, sore throats, multi-joint swelling, joint pain, no without swelling, impaired short-term memory and concentration problems, okay? So let's go. I'm going to divide my talk on different things. So now we're going to have what we know about passive surveillance of ME/CFS. So it's mostly on number of official cases. I searched the literature. I didn't do like a systematic review and I didn't register, but it's mostly what I found in the literature over the years. There are like 4 major studies, and you have one study come from South Korea, another one from the United States, another from England, another from Norway. They are related to different databases, and it's also important. So in South Korea is the database, let's say, of the national health system there. But for example, in United States is the Optum. So it's like a health insurance company. So it's like not exactly the whole population in the United States. England is the hospital episode statistics. So it's hospital data. So it's very specific. And then in Norway is actually close to the National Health Registry. And the time periods are different. And so the prevalence across this, so you have in South Korea, 58 cases per 100,000 individuals in the population. That's the minimum that we found in this. And the maximum is actually from England, 159 cases per 100,000 cases. And I'm just going to highlight something that is more than just this table of numbers. So it's not a coincidence that 159, the highest number of cases, is from England. And why? Because you have there long periods on the database. So they analyzed the database from 1991 to 2019. And actually, if you go back to the case criteria, the first one, the Fukuda, is from 1994. So actually, they have more cases that actually don't comply with, let's say, modern case definition of the disease. So you can have much more cases that we say maybe misdiagnosed if we do it the diagnosis nowadays, okay? So the annual incidence, so in this database, they also analyze incidence. So you also have around 45 new cases per year in South Korea, and 25 cases in Norway, around that, in this period of 2008 and 2012. And then in the United States, you have annual incidence that is slightly higher, from 73 to 189. And this is something, there's some Americans here in the audience, so probably they will understand that actually the case definition that they use mostly there is the 2015 Institute of Medicine criteria, which is actually less restrictive than the other ones. So that's why you have more cases there. Okay, if you would do other case definition, probably you have less cases. So just want to give you this research paper from Norway. So it's the data from one of these database analysis. So they actually found out in this study period around 6,000 diagnosed patients, and you have the majority are women, so it's around 4,400 women, and in men 1,400 men. So the ratio in the official records is 1:3. So it's when you do studies, you should try to have this kind of ratios, okay? This is the annual incidence. It's nothing, very exciting, but this is just a time series of that time periods. It just fluctuates over time, but it's mostly, let's say, constant. And this is the distribution of cases per age divided by gender. And so you have men and women. And what I want to highlight here is that in both sexes, you have peaks of cases around puberty and in around early stage of career. So let's say between 30 and 35, okay? So this is, let's say, the age at risk, at the highest risk, okay? So the suggested risk, only by this analysis, these two analyses, like being a woman, so you have more women than men. Then you have the poverty and early stage of career as risk factors. And I didn't have that data here, but actually many of the cases were, let's say, generated by infections. And I put it in between brackets, viral infections, because a lot of people actually report viral. But you also can have other kinds of infections. Okay, so just for you guys, I'm taking the chance of putting all my thoughts on these slides. It's a very ambitious talk. So my limitations on this data is that first of all, you have very simple demographics like age, gender, a residential area. And this is the important stuff. The data is biased towards severe cases because this is the ones they're going to pick up in the national health systems, because the mild, moderate, then probably they will be at home. The other thing is that we don't know what kind of case definitions they apply to the patients if the countries don't have like a very strong guidelines. So you can have like sub-diagnosis to poor disease recognition by health staff and no disease diagnosis that that they apply. So we don't know what kind of if there is a possibility of misdiagnosis in these cases. And I'm just going to show you to convince you that. So that's why I'm making the case, if you understand, I'm making the case for a construction of official guidelines for research and on the national health systems to have like a specific diagnosis, so that we know what kind of diagnosis people are applying. So the problem of misdiagnosis was illustrated in this paper published last year. It was a study conducted in California, in Kaiser Permanente, which is, I think, like a health insurance kind of like consortium. So they used the case definition of the 2015 IOM criteria. The study was not exactly to estimate prevalence or incidence, but so they went to the database and they actually searched for ME/CFS diagnosis, and I put it there, the codes, so that you can see. So it's ICD-9 and ICD-10, and these are the different codes that they used to pick up the cases. So they actually found out there were 1,000 individuals, around 1,000 individuals with these codes. Okay, when actually they contacted the patients and they did the reanalysis. So they ask again, what kind of symptoms do they have? Did a clinical reassessment, let's say. They found that only 22% actually complied with IOM case definition. So what I'm saying is this, is that's only 22% they comply with the recommended case definition of ME/CFS. So what about active epidemiology surveying of ME/CFS? So mostly I'm just going to go briefly about survey-based studies. And I just want to bring you this reference. Probably some of you already used it in your own papers. It's a systematic review of prevalence of chronic fatigue. Okay, and is nowadays 259 more than 259 citations in Scopus. This is like highest papers cited in the database. And I just wanted to highlight something here that most people don't pay attention. I'm just a statistician, right? And I pick up these little things. This is inconsistency. So they search the literature, and at some point they have articles that met their inclusion criteria, and they have 46 studies. But when they analyze the data, they actually analyze with 56 data points when they actually do the pooled analysis. So it means that some studies reported prevalence of ME/CFS using these case definitions, but then they are using it in the analysis, so they are duplicating the data. Okay, so this is what people are quoting in papers. The average prevalence, all the studies that they were conducted, the average prevalence is around 1.4%. The aggregated prevalence, okay, is just divided by the prevalence divided by actually, if you count all the cases and then divide by the total sample size of all the studies, this is the aggregated prevalence, so it's around 0.4%, and the prevalence estimated by meta-analysis is around 0.7%, okay? So it's around 680 cases per 1,000 individuals. Like I said, this is actually flawed for me, it's a flawed systematic review, okay? So the data has actually multiple case definitions. So you're putting things together that are probably not together. You include studies that actually comprise a too long period of time. So 1990 to 2018. So the Fukuda criteria was not even, put it out there. So, and actually they include studies on that. They also included the studies that don't represent the whole population. So, for example, they had studies only in adolescents, and adolescents can have different prevalence, and also this duplicated data. So, just my convey message is that we don't know much about the prevalence, but be careful with the citation of this paper, okay? And now, just bringing back to what actually we did in Euromean, I was in the epidemiology group, and we had the mission of doing a systematic review of prevalence and incidence in studies done in Europe. So you see that this is a published paper in 2020, I think, and our citation index, it's much less, so it's much less impactful, so it's only 50. But we're very much more restrictive in our analysis. So in the end, we searched the literature, and according to our inclusion criteria, using the recommended case definitions and all that stuff, randomness of surveys and all, we only had 3 studies that actually could give us some information. One of the studies, and if I must say, and if I can advertise it, was conducted by Luís Naculti, who is there. So it was done in 3 regions of England, and they used 2 case definitions, CDC Fukuda, or 94, a Canadian consensus criteria, and actually the estimated prevalence is 0.2%, and if the Canadian, which is actually more restrictive, was 0.1%, okay? Then there is another study conducted in Iceland, and the prevalence was around 1.4, okay? So for me, it's the best study conducted so far is actually done by Luís and his team. Because actually what they did, it was a tremendous effort, and if you can share a little bit what they did, is that actually they review all the health records themselves. So even that they had complying of the case, they had like the record of case definitions, the diagnosis, then they review to confirm the diagnosis, not only believing that the data is telling you something. And this is for me the most believable estimate for prevalence so far. So it's around 0.2% for the Fukuda and 0.1 for the Canadian consensus criteria. So if you want to take it something from this my talk, this is for me the best estimates so far. So now going to epidemiology of long COVID, and I just want, if I have time, I don't know how much time. I have time. Okay. 10 minutes. Well, it is more than enough, huh? Quick note on diagnosis. Again, long COVID doesn't have a biomarker, so it has the same problems of ME/CFS case diagnosis. And across the countries, they have different, let's say, case definitions. Most people use the WHO definitions, where actually you need to have, and this is really important, you need to have a suspected or a confirmed COVID-19, let's say, case with some kind of like a rapid diagnostic test for detecting SARS-CoV-2 infection, okay? So this is really important. Then you need to have people reporting symptoms after 3 months, which is not exactly the cutoff for the ME/CFS, where actually you need to have 6 months, okay? Then US, UK, other countries, they have slightly different definitions, but they more or less rely on this. So I'm just going to bring you here a review that was published last year. And so what you can see here, I don't know, so the total prevalence was around 2%. And so this study was conducted by the Official Statistics Office in the United Kingdom, and they conducted like a survey, okay, if they had a confirmed case, if they still have symptoms after these 3 months, okay? So this is the long COVID, 2%, but you have bear in mind that the definition, when you compare ME/CFS with long COVID, ME/CFS has this time window of 6 months that you cannot have the diagnosis, but long COVID is 3 months. So by that, you're just increasing the prevalence by this amount, so, okay? Here in this plot, already you can see what's kind of like the age risk factor. So it's around, again, 30 years old, 40 years old, around that, 40. Women are a little bit more affected, but not as much as in the ME/CFS, okay? And a lot of people actually are handicapped. They stay at home, don't do anything, so, okay? Okay, so, and this August, in 2025, someone actually from Yale, a team from Yale actually conducted another systematic review and a meta-analysis, and they put it all together, which is, I think it's not right, but anyway, so they put all the literature, screen for all the literature on long COVID, and they try to understand what was the global prevalence of long COVID. and it was around 35% among the COVID-19 cases that were detected, okay? So this is the long COVID, is the prevalence of long COVID in the population of COVID-19 cases. It's not the overall population, okay? This is first of all. Then you have, this is the variation, what you see on the rest of the plot is on the top is the global prevalence, and then on the rest is some other things like where actually you have the variation of the prevalence across different regions. Okay, so I'm not going to bother you a lot about that because I want to go, to one of my last slides. So the incidence, if you go to the incidence, this was a paper published in 2024 in Nature Medicine from the team of Eric Topol, and what they see is they had around 400 million long COVID cases. Okay, that was the global estimate. For me, it's like you need to be very careful with putting out these numbers because we are talking about in mathematics, we're talking about extrapolation. We're not talking about interpolation, which is easier to do. Okay, so under the assumptions, a lot of set of assumptions, you can do the extrapolation, but with a caveat that is actually you don't know what's happening there. So it's around 400 million cases globally on long COVID. What about risk factors? Of course, here is a conference with medical or clinicians. You must know all of this, but pre-existing conditions, of course, being female, coming from a deprived background, and then in the beginning of the COVID-19, you have multiple symptoms, and so on and so forth. Okay, so what I want you to show you is this slide, and this is the most important slide of my talk. And I brought this study was conducted in Barcelona in a small town, and they did what actually epidemiology should have done, which is they did active and passive surveillance. And they did it in this Consorcio Sanitario de Terrassa. If there is someone from Barcelona here, I apologize if I mispronounce this. So it's a community of 200,000 individuals in the outskirts of Barcelona. And what they did, so they went to the health records. So they had a total number of cases, 376 cases, more women than men, okay? And then when they did active surveillance, actually they found out more cases, okay? So the prevalence that they found in this region is around, in women, 333 per 100,000 individuals, and 160 per 1,000 men, okay? And what's the problem with this? So this is just to tell you the number of cases over time. And you don't see anything strange here. So here, this is from 2020 to 2020, and there's a drop there. Almost goes to zero. You know why? Because people stop diagnosing COVID-19 with a rapid diagnostic test. So what happens is that vanishing COVID-19 is because of this. COVID-19 disappeared, so long COVID no longer exists. And this is mostly what I wanted to say, is that we wrote, Antonio, Jaime, João Carlos Wink, we wrote a paper on Ata Médica Portuguesa that actually we say that most of these diseases, ME/CFS, I would say long COVID, I'm coming from a malaria background, Ebola, dengue, they had outbreaks, and actually people suffer from the same things, the ME/CFS types. But because the outbreaks finished, this disease disappeared even from the global burden of disease. We had data from post-fatigue or post-Ebola fatigue syndrome in 1 year. That was in 2015, and then the next report, that disease disappeared because the Ebola outbreak disappeared. Okay, so what about Portugal? Just very briefly, again, extrapolation. So if Portugal was England, okay, this is what we get. Okay, so what we are doing is like the data from England, if it will apply to Portugal, you would have 180 to 300 cases per 100,000 individuals, okay? Or 90 cases to 120 cases per 100,000 individuals if you use the Canadian consistency criteria, okay? This is the, like I said, if Portugal was England, okay? But then, so if you do it with the data from census, okay, you actually can calculate how many cases, really cases, you can have in Portugal. So this is a population size of around like 10 million, with individuals with age greater than 9 years. So the prevalence, if you assume that the prevalence is 50, so the expected number of cases is 455, and a prevalence of 100, you can have, I mean, 50 is per 100,000, okay? Then your number of cases is 950. Finally, just very briefly, I had the luck of having a PhD student that was analyzing the database of the mortality and morbidity of the Portuguese hospitals. So I just, out of curiosity, I asked him, can you just see if you have like cases of ME/CFS or ME/CFS or any other things? So ME/CFS, this is what you get. 100, this is actually mostly 100 cases per year from this, all of this. So this is for ME/CFS, ME, and this is for chronic fatigue. So it's really strange because you don't have, most of the people don't have chronic fatigue, they actually have myalgic encephalomyelitis. So it means that they had an infection, so have some kind of inflammation. So what I'm going to say to you is that passive epidemiology has some problems. You only deal with official records, subdiagnosis, no control for case definitions, and all that stuff. And you have a prevalence that I think is less than 250 cases per 1,000 people. And I'll just finish this acknowledging all these people. And many of them are here in this room. And of course, I always have to say thank you, not only to Joan, but also to Ileana and Luis that they actually, they brought me to this field, okay? And I know I'm happy to be here, and I'm happy to answer questions if you have anyone. Otherwise, you can come to me and we can have a chat. Thank you. Yes. It's very difficult because I speak a lot. No, I'm just. Okay.
My name is Diana. I'm Portuguese, an academic and a psychologist and a patient.
Okay.
And I just want to thank you because before I got my diagnosis, I wrote you on LinkedIn. I was desperate. 3 years searching for explanations of my symptoms. Nobody could tell it. And you helped me. So thank you so much.
It's okay, thank you.
A very generous person. And also, I'd like to thank you, my doctor, the doctor that gave me the diagnosis, that is here, Doutora Patrícia Pinto. She has been doing a wonderful job. And I felt very relieved when somebody understood my symptoms. That's it. Thank you.
Okay. Thank you for the comment. I'm very grateful because I'm a mathematician and I'm helping in the clinic. But that's the beauty of, let's say, of science, is that even in our own corner, we also can help. So never forget, actually, don't be desperate, and they always can help in any other way. You always have your own expertise. Okay, thank you.
Thank you. Okay, let's move on. Thank you, Nuno. Let's move on. The next segment of this meeting will be moderated by Jaime Branco, which is, I already introduced him, but let me do it again. He is a full professor at Nova Medical School. He is a clinical assistant at the Egas Muniz Hospital. He's a rheumatologist by training, and he's also a member of the organizing committee of this meeting. So without further ado, Jaime, the floor is yours. He will take us all the way to lunchtime, so I can relax. I don't have to worry about time. That's going to be your job. Thank you, guys.
Well, good morning, everybody. First of all, I want to thank for the organization of these conferences, and Joan is really the really motive for us to be here and for doing this effort and this second conference. And I want to thank Joan Hoffman for that. And I think all of us, patients, medical doctors, other professionals, must be grateful for this initiative and this, how to say it, energy she has. She thinks that she has no energy, but she has full of energy when she thoughts to help other people to manage it. And it's about it what I'm going to talk in this first block. Diagnosis made, patients asks for answers, several answers, and therapeutic says one of those answers, and one of the most important of those answers. And as you know, all these clinical entities, ME, CFS, and long COVID are can be classified as post-infection syndromes, and we don't know already, and really physiopathology of these entities. So it's very difficult to treat this type of diseases of syndromes. But there are answers we must give to our patients. They must continue to live, to work, and to be in family with friends, and they must have answers to give to their husbands, their children, and mostly of the difficulties I see in my patients is they have no answers from some of our colleagues, and that is in addition with their disease, another disease, and we must apologize those patients who have months or years or without treatment, or even without diagnosis. And this first block maybe can accelerate some of our knowledge, and so we hope to have some highlights evolving approaches to the treatment of these clinical entities. We are going to have 4 talks, and the 2 first are online. Colleagues are not here with us, Susan Levine and Danilo Bonosenso. And after the coffee break, we have 2 presential talks from Caroline Kingdom and Luis Nakul. After each talk, we can have 1 or 2 questions, but we have a period before lunch to have questions and answers from our colleagues, and also to discuss the 4 presentations. Okay, are we ready to have the first presentation of Susan Levine? Well, Susan Levine is an internal medicine and infectious disease physician. She has been treating patients with ME and CFS for nearly 20 years. She's a physician at the Center of Innovating Neuroimmune Disease at Cornell University in New York, and a member of the working group that provides expertise and resources to the Stanford University Center for Collaborative Research in ME CFS. She was a reviewer of the 2015 report produced by the Institute of Medicine Committee on Diagnosis Criteria for ME CFS, and then served on the Chronic Fatigue Syndrome Advisory Committee. Susan? We don't listen.
Elsewhere to enrich the knowledge base on ME/CFS, chronic fatigue syndrome, myalgic encephalomyelitis, and on long COVID. Briefly, there are parallels between these 2 conditions, and the only silver lining relating to the advent of long COVID is that scientists are able to study the pathophysiology of these similar conditions closer to the onset of illness or disease process. My focus today will be on discussing 4 novel treatments that are being used to treat these conditions. In addition, if there's time, I will introduce some yoga poses or asanas that I have found helpful in reducing excess sympathetic output in patients with ME. The first of these medications that I'll discuss is rapamycin, which many of you have heard of, I'm sure, and there's been a recent publication as well. Rapamycin relies on the absence or depletion of an autophagy protein, ATG13, which in mouse models who lack this gene develop severe fatigue after running on a treadmill. Rapamycin acts to enhance the production of this autophagy protein and thus may help with fatigue. The second group of molecules that I'm going to discuss are plasmalogens. These are lipids containing a novel chemical structure and which are also found to be depleted in both ME/CFS patients and in those with COVID, long COVID. They appear to be depleted in ME/CFS and in normal aging, in Parkinson's disease, and also in Alzheimer's. The group that I'm part of, Centers for Solutions at Columbia, has published in the past on diminished numbers of peroxisomes, which are little organelles in the cells that normally produce plasmalogens. So this is an interesting area of research, and I think these supplements, the plasmalogens, are very well tolerated and could be very helpful. The next set of meds I'll discuss are the GLP-1 inhibitors, which have anti-inflammatory effect. These are the drugs that were originally developed to treat diabetes, elevated cholesterol, and help in weight loss. These medications, which act by enhancing glucagon, which is a hormone that regulates blood sugar, also, interestingly enough, have a strong anti-inflammatory and specifically mast cell stabilizing properties and optimize glucose and insulin metabolism. My practice is using this quite a bit, and thus far we've had some success. It's early days, but the good news is they don't seem to cause the gastrointestinal side effects that are found in the higher doses of these medications. I'll also discuss briefly oxaloacetate, which many of you have also heard about probably, and on which there's been a few publications. Oxaloacetate is part of the Krebs cycle, which helps us derive energy from food, and which is not working as well in ME patients. The aerobic metabolism in ME is faulty, and so many patients utilize the less efficient anaerobic pathways for energy. So let's go back to start our discussion with rapamycin. As many of you know, there have been very few interventional studies done in ME patients. Part of the reason is, of course, lack of funding for this orphan disease, which is so prevalent and causes so much devastation around the world, but also the lack of a reliable biomarker that can be followed to determine whether the person is responding to a particular intervention. And the lack also, surprisingly, and this is a little difficult to explain, but of a normal control or a placebo that could be available to offset the study drug. So that actually was an impediment in the rapamycin trial. So this study was done in part by the Bateman Horne Center and Doctors Kaufman and other doctors on the West Coast in the US. And they used this novel drug, rapamycin, which was originally developed to prevent organ transplant rejection. So it has mild immunosuppressive properties. However, when people hear that, they think that they're going to really suppress their immune system, but it's actually relatively mild. And in people who have a normal immune system, it hasn't caused any further deterioration. Rapamycin was studied, as I said before, in about 80 ME/CFS patients as part of this recently published study. And they used several different doses, but the doses they found most successful were 6 milligrams weekly. And they worked up to that. And we do that too in our practice. We start out with 1 milligram weekly for a month and then escalate by 1 milligram every month. So the second month is 2 milligrams weekly, et cetera, until we reach the 6 milligram weekly. And what they did was this group studied blood every month and found that there was an increase in the autophagy producing capability of the patient, statistically significant over those patients who did not receive the medication. So what it's doing is it's augmenting the capability of the immune system to rid itself of abnormal, like cellular detritus, the things we don't need, and therefore improve the inflammatory situation. And this in turn led to improvement in patient subjective complaints by measurement with fatigue scales, standardized fatigue scales, like the Beck Depression Inventory, the Chardin fatigue scale, and others, found a fairly robust improvement in fatigue by the use of rapamycin. What was missing from this study was an adequate placebo. There were problems with developing a placebo drug that would adequately mimic and taste the same as the rapamycin. So in other words, the people who reviewed the study couldn't arrive at a good placebo, and that's often a problem because people can discern whether so it's not a completely double-blinded study. But in any case, it's well constructed, and they're doing more to enhance it. There's the second study that's currently ongoing, and that is going to include more principal investigators. So I think the thing to do here is to monitor the patient monthly with CBC and chemistry profiles, and to try to reassure the person that these are not heavily immunosuppressive drugs in most cases. Let me move on to the next category I wish to discuss, which are the plasmalogens. These are available through various internet-based stores. There's a Long COVID store, and I can provide the access to that later. And once again, these are lipids or fatty molecules that have a novel chemical structure and that are found to be low in patients with ME. And again, there have been several publications which showed altered metabolism of fats in people with ME, too few middle chain size fatty acids, and that leads to inadequate reduction of neuroinflammation, specifically in the brain. And mast cells largely reside in the brain. People think of mast cells as allergic cells only that can cause congestion and the typical allergy, hay fever symptoms. But mast cells are actually responsible for producing pain, sleep issues, and memory loss in ME/CFS. And anything we can do to reduce the production of these inflammatory cytokines, specifically in the brain, is beneficial. So these plasmalogens are a group of molecules, and I'll provide some more specific information about potential dosing of these, and which are typically front-loaded in the beginning of treatment. So one would start with 3 times the final dose to take that for 2 weeks, and then end up taking 2 tablets daily thereafter. So we start out with 6 tablets daily for 2 weeks, and then continue with 2 tablets afterwards. Again, I think it's helpful for patients, and we're trying to develop what the best, least inconvenient method is for patients to assess how they're reacting to these medications. So sometimes people keep a diary. They have apps where they measure like the number of steps they can do, and we're trying to develop an app-based assessment tool where people can weigh in on reduction of sore throats, pain, improvement in sleep, quality of sleep, ways of measuring the benefits or side effects of these different interventions. Now, let me come to the GLP-1 meds, group of drugs, which rely on the enhancement of glucagon producing capabilities. So glucagon is the opposite. It's a hormone that's kind of the opposite of insulin. And what it does is it enhances the body's response to changes in blood sugar. And there's evidence that there's some impairment of that in ME patients, and also in patients, obviously, with diabetes and hyperlipidemia, and in obese patients. The drawbacks of the GLP-1 drugs have been in the media and have largely been related to GI side effects and pancreatitis. we have found that at about 1/20th of that dose, that there actually is some improvement in ME patients in terms of lessening inflammation, improving fatigue, and there's some evidence that these group of meds also reduce mast cell products. And so obviously that ties together very nicely with our theory that a large part of the physiology behind ongoing symptoms in ME patients is this persistent inflammation. So, you know, I think this is an interesting area to pursue. The last supplement that I'll discuss is oxaloacetate, which has been written about a little bit, and I'm sure people have seen it on the internet. Oxaloacetate is a component of the Krebs cycle, which is the human respiratory cycle, which typically uses oxygen to promote metabolism of sugars and carbohydrates like glycogen. Oxaloacetate seems to be missing or depleted in a lot of people with ME. And so as shown also on some of the 2-day CPETs, and if anyone in the audience has ever seen someone like Betsy Keller or seen David Systrom, they know that preferentially in ME patients use anaerobic metabolism, which is much less efficient than aerobic metabolism. So the theory behind providing oxaloacetate to patients is that we can switch over the mechanism of oxygen and energy delivery to tissues with the use of this supplement, oxaloacetate. Again, the dosage hasn't been completely worked out. People usually recommend a loading dose of 2 500 milligram tablets twice a day for 2 weeks, and then down to 500 milligrams or 1 gram daily, depending. The dosing on a lot of these things is iffy because, again, there haven't been large studies to determine optimal dosing. And I suspect it varies from patient to patient anyway. So that's oxaloacetate. And there are other molecules like this, like carnitine is another example of a supplement that's part of the Krebs cycle that has also been found to be depleted in ME patients.
Well, Susan, are you there or not? I wonder if Susan is going to be with us till the end of the round table, or she's not able even to listen some questions or commentaries about the talk she gave us. Okay. 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 So let's move to the second presentation, and the second presentation is about pediatrics, and our colleague from the Gemelli University Hospital in Rome, Danilo Buonsenso, is going to talk about pediatric ME, CFS, and long COVID, clinical care models, and diagnostic gaps for younger populations. Danilo is a pediatrician at Gemelli University Hospital in Rome and member of the research committee of Global Health Research Institute of Catholic University of Rome. He has a PhD in public health and molecular sciences. Danilo, please.
Hello, you hear me, please?
Yes.
Okay, and you see my slides as well, right?
Yeah.
Okay, perfect. So first of all, thank you very much to all the organization for inviting me. I'm very sorry I could not join in person. I loved being in Porto, and I'm also a passionate of surfing, so it would have been a perfect destination for me. But I've had a very last minute issue, and I'm really sorry. And I also wanted to congratulate the organizing committee, because I'm seriously, I'm not aware of any conference on this topic with such a multidisciplinary coverage. So I'm really proud to be part of this meeting. So I will talk about pediatric long COVID and CFS in general, though most of the data you will see are referred to long COVID. I want to, and I know there may be some differences in long COVID and CFS, but my personal feeling is that these conditions go under the same umbrella of post-viral conditions, and they deserve the same equity in access to care and research. So this is why I usually do the same things to both patients until we have more data and more evidence to highlight us to how to treat CFS or long COVID differently. So far, I consider them from a real-world clinical practice, the same condition in terms of diagnostic and care models. These are my conflict of interest. I've received funds on long COVID to study long COVID by Pfizer and Roche, but none other influences. I've written a book of long COVID. And my other declaration is that I know very well that we need trials and better evidence to improve the care of CFS and long COVID, particularly in children and adolescents. I know very well that we need funds. I'm trying very much to apply to funds to study more these conditions. But unfortunately, referees sometimes reject us because they themselves don't know anything about this condition and reject our applications due to no reasonable reasons. And the other point I want to declare before my presentation is that, as also the presenter mentioned before me, long COVID sometimes, although we don't have a very clear evidence about how to manage them, we need to be aware, and this is my straight position, that long COVID can be a very severe organic condition, like any other condition, cancer. Some patients, even young people, die due to this condition, or sometimes people take their own lives due to this condition, to highlight how much severe in this condition. And this is why, although I'm aware we need trials and more evidence, but sometimes in medicine it's very much accepted to have off-label indications for very severe conditions where we don't have other options. This is great for severe infections with multi-drug conditions, cancer, but still people question this may be reasonable for long COVID and CFS. So when it happened to me to have these severe cases, I asked myself, should I just say wait and see what happens, or okay, this is a very severe case and maybe we can do something. And this comes from this. This is a very long debate, because many times even my colleagues tell me, first do not harm. But first do not harm is a very mainstay of our practice, and of course I do respect what Hippocrates said thousands of years ago, first do not harm. But sometimes even doing nothing, in my personal opinion, is harming, particularly when now we know some conditions like since 50 years, like CFS and long COVID. And my personal feeling is that when we have the most severe spectrums of these conditions, we do have to do something, because nowadays we know a lot about the pathophysiology of long COVID and CFS, as we will see during the program. And the other point is that in pediatrics, most of the things we do are off-label, because most antibiotics are introduced after trials in adults and then translated in pediatrics without specifically pediatric or neonatal trials, or even preterm newborns. We don't have trials for preterm newborns, and we use the off-label. So this is why I do, in some selected cases, something for these children. The other point I want to highlight is that nowadays we are at the end of 2025. So I'm not talking anymore about what is long COVID in children and the epidemiology, because this was the very first publication on long COVID we did in 2021. We are not in the scenario that long COVID is a preliminary evidence. We have millions of patients all over the world. Long COVID has been literally described everywhere in the world, including Latin America and Africa. We are now at the level of knowledge that we know that even in children, like in this study we published some months ago, but this was also replicated by other centers, there is a clear chronic inflammatory signature in patients with long COVID, even in children and adults. There is endothelial cells activations. So the microcross theory has been widely replicated in every country. So long COVID is an organic disease, and we know a lot nowadays. It's not preliminary anymore. We know that long COVID and ME/CFS may have different subtypes of clinical presentation. Some patients may have all of these cardiorespiratory, musculoskeletal, abdominal, and neuropsychiatric symptoms. Some may have a predominance of some symptoms, like some may mostly have a cardiorespiratory cluster, a fatigue cluster. Some may have a neuropsychiatric cluster. So we know a lot nowadays. So we have to move from the period where we needed more evidence. Of course, we need more evidence, but we need to translate our efforts on pharmacological studies and biomarker studies. And in the meantime, as we know, long COVID since 5 years and ME/CFS since 50 years, we really need to implement daily care, daily clinics that offer simultaneously clinical care and research, because we need to know more. So every single patient must be offered real life practice, but also research opportunities, because it is true that we don't know yet very well what is the ideal model of caring for these patients, and I'm proposing our model here. But whatever model you decide, the very most important step that should be done in every single country in the world, and hopefully recognized formally by a government, is to recognize that long COVID and ME/CFS are real organic problem, and these patients need to be offered any sort of care. This is the very first step. So do whatever you want. You can also just follow up patients, but offer a formal care where patients do feel to be accepted. And secondly, once you establish a pivot center within your countries or your region, of course, try to establish a network with family pediatricians and family physicians from the outpatient settings, in order that at least patients can receive a clinical diagnosis and be referred to a referral centers, at least for a clinical follow-up. And ideally, as we are knowing much more, we are interconnecting a lot with international experts as today. We need to develop local guidelines. Again, there is not one guideline who is better than another, but try to do your best based on your local resources and on the literature. And this is basically a very diagnostic summary, a number of basic tests we do here in our center, and I will discuss a bit more in details. And this is not a rigid protocol, so this is a number of investigations that we do based on main clusters of patients. Like, for example, I will focus a lot on this central pathway because most patients suffer from fatigue and postural orthostatic tachycardia syndrome. So once a patient have a diagnostic criteria of long COVID or ME/CFS, we move to a diagnostic pathway because This diagnostic pathway, although may not have a clear therapeutic response, but it's important to have a recognition and sometimes even to provide certificates in order that patients can have social support in terms of money from the politic backgrounds, because patients may need to stop working or to work less or to go to school less, because this is part of pacing. And as a reminder, the fatigue of patients is clearly due to muscular abnormalities which worsen after exercise, because these patients suffer from post-exertional malaise. So this is not just fatigue due to lack of movement, because these patients like stay in bed most of the time. The muscles of these patients have organic differences compared to the muscle of patients that simply do not do practice. And indeed, where we do the cardiopulmonary exercise testing in our patients compared to healthy controls, as you can see, several differences were statistically significant. And we already some years ago documented that patients with long COVID, when CFS, when do a cardiopulmonary exercise testing, do have objective muscular and cardiorespiratory abnormalities compared to healthy controls. And like seen in these patients, the cardiopulmonary exercise testing, unless we know that patients suffer from a very severe form of post-exertional malaise, but at least at base can offer a baseline and sometimes also monitoring over time, like this patient that, as you can see, in 2 years was able to move from a very basic protocol to a more complex protocol here, as you can see from the 7 to 12 protocol, like the ability of doing the fourth move from submaximal to maximal, and like signs of pulmonary hypertension move from unlikely to likely. So you can also monitor improvements over time using the cardiopulmonary exercise testing. But one of the cornerstones of these patients is that more than 50% of these patients suffer from post-orthostatic tachycardia syndrome. And despite this is documented since decades, most clinicians still think that when patients feel tachycardia, palpitations, or fainting, they think this is due to psychological or psychiatric issues. But it is very simple to document the POTS in children and adolescents as well as in adults. And you can either use a very simple 10 minutes 10 test or a 24-hour electrocardiogram with heart rate variability. The heart rate variability is a number of parameters that we have documented even in children do differ when you compare the patients with healthy controls, and this heart rate variability can discriminate between the sympathetic and parasympathetic imbalance compared to healthy controls. So basically for us, a 24-hour electrocardiogram, a 10 minutes 10 test, and a cardiopulmonary exercise testing, if patients can afford to do that, is like the first line physical approach. As you can see, this patient who was sent to the psychiatrist, as you can see, only standing up or only going to the toilet, his heart rate moved from 70 or 80 to 140, 150, only walking a few steps. Or as you can see in this case, this is another girl, again sent to the psychiatrist at 14 years of age, despite she was very fine in terms of mood, and only when she woke up in the morning, or here was being in a school, only going to the toilet at school, her heart rate, the baseline was very high, 100, and only going to the toilet, this moved her heart rate to 175 to peaks of 200s. And her POTS usually respond very well to ivabradine, even in adolescents. And as you can see in this case, the mean heart rate moved from 100 to 75, and peaks moved from 200 to a maximum of 150. And this was along with the clinical improvement. Now, so this we know that ivabradine can provide, improve the balance between sympathetic and parasympathetic system, and therefore controlling the heart rate of these patients. And although we are aware that not all patients respond to the first line treatment, and this is why we need a personalized and step-by-step approach. We are doing some studies to predict who will respond or not to ivabradine based on our heart rate variability parameters, but this is still research practice, so I will not go in details. But this is everything to say and explain why, in a step-by-step approach we do in our diagnostic and care model, we start with a 24-hour electrogram, then the 10 minutes and test, and if the patient does not suffer from severe post-exertional malaise, with the cardiopulmonary exercise testing. And first of all, if we document POTS, the first we do, we try to regulate POTS with ivabradine. But as I said, we may need another step, because patients, for example, may suffer from insomnia, chronic headaches, pain all over the body, and this is why we do to every patient electroencephalogram, the electromyographies, but also the pseudoscan if you cannot do the small fiber biopsy to document the small fiber neuropathy. These neuropathies are very well documented in long COVID and CFS, and not every time, but most of the time, have a good response to gabapentin, which is historically an anti-seizure medication, but it has very good effects in pain control, and last but not least, also has a stabilizing effect on mood. And this is important because some patients can also have a mood severely affect, either due to an organic involvement of the disease in the brain, but also due to a response to a drastic change in life. And this is why, as a step 2, we may need to add gabapentin or melatonin to improve sleep. And this is important because at this level, we are mostly at the symptomatic approach. These medications are usually well tolerated. We have a lot of experience due to similar conditions. And so this is, in my opinion, like the basic approach, the less severe in terms of costs and side effects. However, patients may still not improve. And we know this is widespread, documented all over the world, that particularly young adults and older adults suffer from thromboinflammation following COVID. In long COVID, it is widely demonstrated. Particularly at the beginning of the pandemic, we were doing the lung perfusion CT scans, and we documented that some patients had impairment in the lung microcirculation, very much described in adults as well. And this is an important paper published on Science, so we are referring to the top of the science available in medicine, and complement this regulation with thromboinflammation are clearly demonstrated in long COVID. This means that endothelial cells are hyperactivated. Endothelial cells are immune cells eventually, so they activate the immune system, the chronic inflammation, and the chronic inflammation can activate microclots, which can impair the peripheral circulation. And this is why some of us in severe cases do consider low-dose anticoagulation. And in this regard, I usually prefer to use low-dose enoxaparin or rivaroxaban because at a prophylactic dose, because we don't have macroscopic embolism in these patients. And one of the reasons I use heparin or rivaroxaban is that because these medications have clear effects as antioxidant and anti-inflammatory effects on endothelial cells, and we know that there is thromboinflammations in these patients. So if patients don't improve on the first 2 steps and move to the third steps and consider low-dose anticoagulation at prophylactic doses, they usually are very safe. Again, this may not be enough, and some patients really remain bed-bounded for 20 or more days. They are not able to attend school anymore, no sports, goes out with friends, basically have no life, and some of them have severe brain fog. Really, some of these patients prefer to die rather than living with this CFS or long COVID. And now we have a lot of studies, and these are three of the most important studies in the history of long COVID, despite a brief history. But these three independent studies documented that if you take the blood of patients with long COVID and put it in mice, mice develop the same symptoms of adults with long COVID, meaning that there is some in the blood that can trigger all these symptoms. Most probably they can be immune cells or autoantibodies. And this is why we can empirically and off-label try to block this chronic inflammation in autoantibodies. The easiest, although most expensive tool to do that is using intravenous immunoglobulins, which are used since probably a century in idiopathic immune-mediated conditions. And this is why, as a first step, I do consider intravenous immunoglobulins, or along with or without low-dose naltrexone or cannabis to reduce inflammation, and IgIB to reduce autoantibodies. But again, this may not be enough, and as also mentioned by Susan Levine before me, again, we have a lot of evidence now. This is again science, translational medicine. So we are talking about the top of the science. Not a lot of conditions have the high level evidence as long COVID in the whole history of medicine. And long COVID is clearly an evidence of chronic immune activation with tissue T-cell activation in several organs and tissues like the brain and the gut. And nowadays we do have medications that can control the T-cell activation. And Susan just talked about low-dose rapamycin. Another option can be rituximab, which blocking the B cells block the production of autoantibodies, but also the activation of T cells. But rapamycin looks the cheapest option and the safest at low doses, because this is also used a lot as an anti-longevity medication. Low-dose rapamycin already said a lot, Susan, and this is part of my fifth step for those patients not responding anymore, waiting for new trials, and maybe one day we will move rapamycin to one of the first steps. Of course, all this approach goes along with mental health support, family support, pacing. Pacing remains the most important thing. Social support, meaning that children and adolescents may need to have personalized schedules at school, allowing absentees when they need to rest, allowing scheduling in advance of examinations and so on, in order to make the school experience less heavy as possible. Once we start all these medications, we don't know how to step down. So this is really no evidence about that. Basically, if patients do better for 1 year or more, I very gradually try to reduce the doses of the medications, and once at a time eliminate the most heavy medications, usually if possible monitoring, having objective evidence of improvements with the 24-hour electrocardiogram and the cardiopulmonary exercise testing. So this is my very fast overview. Of course, I'm happy to share my slides if you want, if you need them. If you want to go a bit deeper to our protocol and what we do in our daily practice, I have a blog where you can access every Sunday information. And also I've written a book on that, which is mostly about the neglect that patients suffer. And I've written that not only to educate doctors, but also the family members, because many times family members are the first not trusting our patients. But the trust of these patients is the very first step in terms of care. And there is also a Portuguese version if you may think it useful. And thank you very much again for your invitation. I've finished here. I'm happy to respond to any answers if you have them, or feel free to email me if you want to discuss anything more. Thank you very much.
Thank you, Daniel, for your very interesting presentation. and we have time for one or two questions now. I don't know if you are going to stay with us till the end of the session, or we must do all the questions now. Danilo.
No, I remain online. So you have the Q&A at 12:30, right?
Yeah.
Yeah.
Thank you.
Yeah. So
But
we
we
remain online when it's time of the Q&A.
okay. So I have a first question for you. Do you know if the prevalence of long COVID in the children is similar to adults?
Yes. So it is. I do. We don't have the perfect data about the prevalence, but what I do strongly believe, also based on data, is that it is less frequent compared to adults. It still is a massive amount of absolute numbers, but luckily it's in terms of prevalence much less compared to adults. Yeah.
And what is the age of most prevalence in children?
Yeah, it's mostly adolescents from 12 to 18 years of age, although very less commonly from 6 and onward. But the biggest problem is 12 to 18.
Okay, thank you. Any other question from? Yep. No. Microphone, please. Microphone, por favor. Okay.
Grazie, thank you. I'm just wondering if even in children, they still find a difference in gender, in prevalence.
Yeah, I've heard it, yes. So some studies show that slightly higher prevalence in female, but not every studies. And so basically the gender difference is not as much pronounced as in adults.
Ok, thank you. Grazie, anch'io sono italiana, la saluto, la ringrazio.
Grazie a te.
Okay.
Okay, good morning. I'm Miguel Castelo Branco from the University of Coimbra. A very nice talk. I have a question about, you talked about the immunoglobulins that can produce symptoms in mice models. We know that there are some types of immunoglobulins that are reported in long COVID. It's very difficult for the average patient to do the titration of these immunoglobulins. Can you make a comment on the profiles of long COVID that you are aware of?
Yeah, so basically, it is very true what you said. We have many phenotypes, but as you said, the average patient and the average center, including myself, we are not able yet to have in clinical practice, in real life clinical practice, the possibility of discriminating those patients having specific autoantibodies or immunoglobulins that may trigger long COVID. So my personal approach is that when a patient is severe enough to think about moving at the third step, I do empirically try as off-label IgIV a few times, every 1 to 2 months, 2-3 times, and then we see if patients tolerate without major side effects and he has clinical improvement, we go forward with IgIV. If patient has either side effects or no improvement at all, we stop the IgIV. Because as you said, those findings I showed in those 3 studies, mostly from New York, but one was from Europe, from USA and one from Europe, they are not available in clinical practice. So although we know that we have different subtypes, we don't know how to translate in real practice who will benefit from each treatment. So this is why I do a step-by-step approach, trying, everything from the simple to the most complex, because we don't know how to predict yet. Of course, I start only in the more severe patients, as I mentioned several times.
Yeah, I have a very brief comment on this, because we know that several of the antibodies that are elevated in severe acute COVID, like the endothelin receptor. So most of the anti-protein G autoantibodies, they are elevated, and there are at least some patients in long COVID that have some of these antibodies elevated. And this brings me to the first talk where somebody said no biomarkers. So until we find these biomarkers, you know, if a patient has 3 autoantibodies and another has 5, the clinical phenotype will be entirely different. And we know that some of these autoantibodies are functioning because of the cardiomyocyte assays. So I think we are still lagging very much behind because we don't have biomarkers. And so I think this should be the next strategy for research in this area. I heard your epidemiological talk, but we don't really have a perfect reference for epidemiology. The criteria are still very variable. And I stop here. My comment was maybe too long.
It was very interesting, Miguel. Thank you for your approach.
No, I totally agree. So that is the priority. But as I said, we may need maybe 1, 2, or 5 years more to arrive to that evidence. And in the meantime, some patients are very severe. So that is why I do a step-by-step approach, because eventually we cannot do those tests we hope to have in some years to each patient. And so we do know from the literature that some 50% of patients can have those autoantibodies, and eventually to the most severe, we try to target them either with IVIG or to reducing inflammation with low-dose rapamycin. We try empirically, when we're like we do in the same way with empirical antibiotics in pneumonia. We try to start with amoxicillin. If in no response, ceftriaxone. If no response, I'm saying like meropenem. No, we do the same here, because some patients cannot wait anymore other 5 years, because some of them, even teenagers, otherwise they will not be here with us in 5 years anymore.
Any other question? One question? Okay. Antonio?
Danilo, Antonio here. I was wondering if you could consider including on your therapeutic approach the watch of outstanding and most beautiful movies like Amarcord. So I would, at least patients when look at this movie, don't think about their own disease, and this can be really, really important. So thank you for reminding us of this masterpiece from Mr. Fellini, which I really miss a lot, because the Italian films were just absolutely outstanding. So thank you very much.
Well, Danilo, we are still there. Okay. About rapamycin, we have already listened to Susan talking about rapamycin. Rapamycin is, I think, is an antibiotic. It was used formerly in transplanted patients, and I think I'm right. I'm not sure, but I think it was it has been a polemic some years ago about the mechanisms of aging in patients using rapamycin. Do you know something about it, about rapamycin and aging factors?
Yeah, so rapamycin has come back in in the global interests with the growing field of anti-aging, and actually there are quite a few studies, even on major journals like the Lancet, use testing the low-dose rapamycin for anti-aging. And we don't have data eventually demonstrating that those patients lived more, but those studies that documented that the inflammatory markers with the long term were lower in patients with using them compared to adult or ancient patients not using them. Obviously, of course, I don't suggest its use yet as an anti-aging medication, but its role on at low doses on the mTOR pathways, which we also have pediatric data showing that there is an mTOR hyperactivation, which eventually is involved in chronic activations of T cells and T cell exhaustion. So its activity on downregulating the mTOR is is very well documented in clinical practice. It is also used in some pediatric immunomediated conditions. So, and nowadays we do have some observational studies in young adults showing improvement in fatigue, and I personally do also have some patients that have completely changed in positive their life with low-dose rapamycin. Of course, again, we need more data to use it routinely, but for the same reason I said in the beginning of my presentation, I do think that it's ethical after informing the patients in the most severe cases to try it as off-label.
And
sorry.
Okay, no, you can finish.
Yeah, because eventually this evidence about T-cell activation, T-cell infiltrations, and mTOR activation, chronic inflammation in long COVID in CFS is not a theory anymore. There is evidence. Of course, as the colleague was saying before, we will need the test to better characterize which patients do have this subtype and will benefit the most from rapamycin. But in the meantime, the most severe cases, either dying or surviving, I think it's ethical to try it.
And do you use it for a limited range of time or not?
Yeah, so really, so as I said, once we starting is difficult, but stopping is even more difficult because we do have some evidence, even in case serious from starting, but it's always difficult how to stop. So I do it very much empirically. So if patients tolerate well the medication and they monitor every month the blood test, urine, the cholesterol, and they have no side effects, I usually leave a patient on a medication for at least a year if the patient is doing well. And then I really slowly reduce in years, because, patients are really worried to stop that, once they are better.
Thank you.
Fernando Pimentel from Nova Medical School. Thank you for your presentation. Coming back to IVIG, I would like to clarify which patients should benefit from this kind of approach.
So, as the previous colleague was saying, in an ideal scenario, we will have in a few years some studies showing a cluster of multiple autoantibodies in some patients and in others not. And those patients with the multiple autoantibodies are, in theory, those benefiting more because we know very well that IVIG blocks autoantibodies in several immune-mediated conditions. But we are not there anymore. So my approach is that one patient is sick for 2 or 3 years, most of the time bed-bound, severe on a bad scale, has not improved with POTS medications, is not improved with maybe low-dose naltrexone, gabapentin, nicotine, or cannabis. So, and is still very severe in the best scale. I just empirically try and see, okay, if you are doing well, better we continue. If you're not doing, if you have not benefited at all from IVIG, we stop it.
Daniel, we have one more question before the break. So, Dr.
Thank you, Daniel. My name is Rowan Gardner from Precision Life. We've been working with Chris Ponting to analyze their DecodeME population, and it's really just to say that our preliminary findings see very high prevalence of variants across not just mTOR, but various regulatory genes acting on that pathway. We'll have a preprint up in 2 weeks' time, and I think that will expand our understanding of the benefits of rapamycin in treating these patients. So a little bit of advertising, but I think rapamycin has a lot to offer.
Okay, thank you. No, this is not advertising, because the preprints are also important for us to adapt, particularly if they confirm the studies or maybe they don't confirm what we know so far, and so we may be even more cautious. So Yes, I'm sure I will be notified somehow when the preprint is out, and I will read the very first day. Thank you.
Okay, Daniel, you are staying with us till the end of the session, isn't it?
Yes, see you later. Okay.
So because I have here two more written questions, but I'm going to now make the break because you are a little bit late, so we are going to reinitiate at 11:30. Okay. For you, 12:30. Thank you. Vamos então, we're going to do now the coffee break. Thank you.
Oh, so nothing's showing.
Probably you need to put some thing here. You know, sometimes you need to click something. This is how you will go forward, but I don't know, they're sitting upstairs. But this would be brilliant, no?
Yeah, it's brilliant, you see, because then I can read, Lucy, when I get to slide 2, all my notes are there. Ah. From the... Okay, so I know how to do that. I think I go to settings. And display. Display. And I think I want to extend. Please use as an extended display already. Because I don't want to mirror. Ask what to show. That's not working. Mirror entire screen. Nothing's working.
I think the problem is, yeah.
I don't know. It doesn't even detect it. Does your PC detect it?
Let's try the other.
Well, I'll find out if he worked for you. Otherwise, I'll just.
Oh no, it detects it. I put allow.
Yeah, it's gone.
Did you press allow?
No, it disappeared.
Well, if it works for you, I'll let you find out because I can't help you.
Because I can email it to him and then I can read this and I can say next slide.
Yeah, should be asked.
Yeah. Okay. Oh, is that him coming?
I think one of them.
Oh, okay. He's seeing to it.
What did you say?
He's seeing to it. Ella, do you mind going up there and saying I can't get anything to show at all?
Not even, yeah.
I can't get anything. I mean, it's not that.
Yeah, you don't accept.
Yes. Yeah, Mario.pinto@Norte. No, I just remembered it. Norte Medico OPT. Okay, so attach. So how's that going to help?
He will.
And we'll say next slide.
Yes. This is
Luis can't get his to work either.
No, he will do the same, but then it's good. So you say next slide, and for you,
Exactly,
you can just...
exactly. I can do the presenter view.
Yeah.
So when I do this, I say next slide.
Yeah.
You might need to say, Caroline. So
Yeah, I will. You will
You'll
need
be
to
my
look
prompt.
at me, and I will just do this.
It's just the stress you don't need, isn't it?
Yeah,
it should work. I don't understand why technology is so brilliant, what it's capable of doing. Because I did it on Zoom. It's oh, I remember. Just turn my phone. Yeah, I must have some good things that time.
Esse é o computador dela que não consegue porque é Mac. Agora, para botar o meu, o que eu... Pronto, o meu está aqui, está ok. Agora você quer tentar no dela, né? Quanto? Perfeito. Ok. Bem, eu vou desconectar porque eu não vou ser o próximo a apresentar, vai ser ela. Então, eu já sei como fazer. Muito obrigado.
Sim. Sim. Prioridade que é trabalhar com os doentes, de todo o tipo de doentes, com todo o tipo de doenças. Desde que nós tenhamos o know-how técnico para os poder ajudar, fazemos isso. Achamos que isso é importante. No caso do nosso instituto, os doentes têm até assento também no Conselho de Administração e na Comissão Executiva. Entendemos que hoje em dia uma investigação séria, estruturada e com bons resultados tem que envolver os doentes. Mas é essa a nossa motivação, é que aquilo que a gente faça tenha impacto positivo nas pessoas que sofrem doença.
E no caso concreto desta doença, deste congresso, consequência na região, qual é a vossa motivação específica? Qual é a vossa aposta?
No fundo, esta é uma situação nova. Esta doença, chamada Long COVID, ou Covid longa, é uma situação nova, mas é uma situação muito importante. E que tem algumas características próprias. Por exemplo, numa parte grande do sistema de saúde não reconhece a existência desta doença. E depois nós temos os estudos que demonstram que
Why can I talk to you about this? So I think I have a fairly unique experience. I visited people with severe ME/CFS at up to 7 time points. So some of them are like old friends. I have actually visited them as a researcher, not as a clinician. So I can't talk to you about drugs or anything like that, but I can talk to you about how to interact with people with severe ME and what their needs are. I think it's afforded me a unique view of the disease and the course it takes over many years. Of course, it does occasionally improve, but most of the time it's fairly static, or indeed it gets worse. I've rarely seen the most severely affected because it's not ethical to ask people who are so ill to take part in a study when life's already full of so many different challenges and the risk of symptom exacerbation is significant. So people with severe ME are often alienated from primary care services. They'll tell me that years ago they used to go to the GP, but the GP really didn't think there was much wrong with them, couldn't help them, didn't really want to follow up with them. We all as healthcare professionals prefer to see people improve and get better, and it's very disheartening when there's so little you can do and when you can't actually even confirm a diagnosis. From my point of view, they're quite wary of engaging in research, particularly following the PACE trial, which was an iniquitous trial that took place in England. People with severe ME/CFS do require home visits in the main. NICE recommends annual visits. And they're often socially disconnected, so it isn't just the medical services they're apart from. In the beginning, I used to ask people with severe ME/CFS if they had a relative or a friend who could be a healthy control for them. And no, they were alienated from their friends. They visited once or twice, and then they got bored, and there was nothing to say. And then their family don't believe there's anything wrong with them, so they don't see anything of their family. So the only person in their lives is sometimes the healthcare worker who comes in to give them care. So at CureMe at the LSHTM, we actually use the SF36 to capture health-related quality of life, and it's very widely used in ME/CFS. So looking at this spidergram, if you look, these are the various symptoms that people have that are captured by the SF36, and some of them are to do with mental health and some of them to do with physical health. And if you look at the physical health components, they all begin with PF. You will see that basically people are hugely impacted. If you look at the physical component summary, which is up there on the left, and look at the red, which is the people with ME, not even with severe ME, you'll see that they're much more impacted than people with MS, and certainly a long way away from our healthy controls. And as you can imagine, people with severe ME are even further impacted. However, if you look at the mental health scores, which are just below the physical component summary, you'll see that they're not so distant. So these aren't people who are profoundly depressed. Staying in bed, being confined to bed, and having no friends and families, of course, impacts your mental health and of course causes depression. But I used to do a lot of work in mental health, and if I said to someone with depression, oh, look, you used to climb mountains, would you like to do that again? Don't even talk to me about that, someone with depression will say. When I say to someone with ME/CFS, oh, look, there's a photo of you on Mount Kilimanjaro. Oh, if only my body would let me do that, I would love to climb Mount Kilimanjaro all over again. So it's a very different type of mental response to this disease. These are longitudinal results from the study. So remember, we visited some of these participants at up to 7 time points. And we've put the whole lot together and looked at it. And again, if you look, slightly confusingly, we've got the most severely affected in the middle here. And you can see that they are most affected. But if you look again at the mental component score at the top, they're actually not very much affected. However, if you look at the GCS7, and the GCS7 is scores put together, so this is all the symptoms that we associate with ME: pain, sleep, immunological response, post-exertional symptom exacerbation, autonomic symptoms. You can see just how severely physically affected over a long period of time people with ME are. And not everyone experiences pain, but when it's there, it can be a constant feature. And sometimes it's exacerbated by exercise and activity. So Eliana, who works with us, was well ahead of the curve and has been passionate about seeking guidance from people with lived experience of ME/CFS for many years, long before it was cool to do so, which in turn not only informed our research, but has also taught us such a lot about living with the disease. The top quote came after discussions around preliminary immunological studies, when we invited people with ME in to have a look at the results and see what they took away from them. And they felt that mild, moderate, and severe were almost like two distinct conditions when they looked at the immunological responses. But they were very keen, as the second quote shows, to carry on with the research. At another focus group, just to illustrate how stigmatized living with ME is, we had a table of people with MS. We have disease controls who are people with MS, and they'd contributed to the study. And one man told us his story. He'd been told he had ME/CFS for many years, but his diagnosis was changed to MS. For him, it was a red-letter day, a day of huge relief. At last, he had a recognized illness, albeit one that would likely further negatively impact his life. So what did NICE recommend as the principles of care for people with severe ME/CFS? I know that as a nurse, my principles are usually based on trying to encourage socialization, activity, and rehabilitation. And really, when you approach the person with severe ME/CFS, you have to put all that out of the window. It requires huge empathy and discipline on the part of the healthcare professional who's not used to dealing with this illness. And it does go against every bone in our therapeutic body. NICE recommended regular reviews and energy management and symptom management, including rest and sleep, physical function and mobility, orthostatic intolerance, pain control, medication, we can't give much in the UK, diet, and cognitive behavioral therapy as an adjunct therapy. So if you're living with a chronic disease or with cancer, or with any diabetes, it's a challenge, and cognitive behavioral therapy can be good to address that challenge. We also talked quite a lot about safeguarding, because historically children have been taken away from parents who've been accused of abuse when the disease has been little understood. I think that's getting better, but it's not perfect yet. So what did people with severe ME tell me as when I visited them, and how can that guide our practice? So one lady told me that living with ME is like walking through treacle. I don't know what the Portuguese for treacle is, but it's like walking through mud. Everything just requires an extraordinary effort. So there can be extreme weakness with severely reduced movement and reduced ability to speak or swallow. If you look at the second quote, when I waken, often in the very late morning, I feel no more rested than I did at the end of the day before. Everything's an effort, no matter how long the time asleep. And I don't know how many of you felt like that in the beginning stages of a dose of COVID, but certainly I did. I woke up thinking, oh, have I got to get up? But that's how it is every single day. So this has implications around timing of appointments. There's unrefreshing sleep or hypersomnia, altered sleep pattern. And you have to think about how you're going to communicate, what time of day, when you're going to book your appointments, when you can expect people with severe ME to be able to respond. When someone visits, I have to choose. I can either eat a biscuit and have a cup of tea or listen and respond. I can't do both. Now, obviously, that has implications for us as healthcare professionals. We need to consider language, clarity, tone, volume, and speed of speech. Reading is like trying to listen to the radio when there's so much interference that you can only hear the odd word. When we think about presenting paper documents to people with severe ME/CFS or presenting a computer screen, we need to consider carefully what they're going to be able to absorb on one page. We also need to consider the entire process of the consultation from beginning to end, making sure not to overwhelm the patient with questions. You need to prioritize measures and consider which ones actually benefit the patient and which ones you're doing just because it's interesting to know. One patient said to me, would you mind just shining a light on my arm to take blood? So I'm balancing 12 blood tubes, an iPhone, trying not to let it get in her eyes, but she just couldn't tolerate any light at all. So sometimes the people I see are lying in bed, they've got earphones on to block out any noise, the room is all dark, and when the carer approaches, they approach with ample warning and with a very, very quiet voice. Just gently touching the patient as you approach them to let them know that you're there. A parent of one girl said to me, please don't wear freshly washed clothes when you visit because the smell of detergent or softener can worsen her symptoms. Another girl I visit has a tea towel put under her door in the morning because when the gentleman in the flat opposite leaves with his aftershave, it can trigger her for a whole day, just coming under the door. So it's really important. Perfume's gone out of the window, huge economy for my husband. And I think very, very carefully about what I smell of when I go in to see a patient. I'm so sorry, I know you just asked me to do something, but I can't remember what. And that's typical. You can't ask a patient to do 3 things at once or ask them 3 questions in a sentence because often they'll remember the first one and then you just have to repeat. So it's better to break things down and ask them gently. And again, sometimes I grasp at words, feeling like a toddler learning to speak all over again. We all know what it's like when you can't remember the same word, but this is like every 5th word in a sentence and the most simple of words. And cognitive difficulties limit the person's ability to take in verbal and written comms as well as their ability to communicate with us. Other sequelae of severe ME/CFS, gastrointestinal problems, nausea, constipation, incontinence and bloating, and these can be overwhelming symptoms for the person with severe ME/CFS. Malnutrition is real and not recognized, and I'm sure many of you have heard of the case of Maeve Boothby in the UK, who died of ME/CFS basically because her nutrition was not addressed despite the fact she was in hospital. I've already mentioned the relationship breakdown in families and among friends, and marriages and partnerships are greatly at risk. And even when I go into someone who seems to have such a happy, supportive partner, I'll get an email years later saying, you won't be surprised to hear that my wife left me. Financial hardship and poverty. People in England love to offer you a cup of tea, but so often a patient will say to me, would you like a cup of tea, but I can't offer you milk. I'm sorry, I would have bought milk, but I can't drink it. I don't drink milk, it doesn't agree with me. And I can't afford to buy just milk like that. I go into flats that are covered in mold because the council's doing nothing about it and the patient doesn't have the energy to fight their case. There is real poverty caused by this disease. And of course, the economic burden on the country is huge. Loss of identity and low self-worth is evident. A deep fear of infection. So I always listen really carefully to what the patient would like me to do when I visit. Maybe they want me to take my shoes off. Maybe they want me to wear a mask, and maybe a particular mask. And I'm always very careful to do that. The first thing I do when I go into a house is very openly wash my hands. I make sure the tap makes a lot of noise and that the patient is very, very well aware that I'm taking every precaution. Since COVID, I take a COVID test whenever I go to see a patient and I let them have the result before I visit. And I think that's very important. And I notice that family caregivers are pushed to the limits of their resilience and beyond. There's very, very little help for these stigmatized people. If you get cancer, people bring you cakes, they bring you flowers, they send you cards. If you get ME CFS, I'm afraid it's not the same deal. So I think it's really important to be aware of all that. And you can use Maslow's hierarchy of needs, thinking about, you know, the right at the bottom, you're thinking about limiting infections, sensory sensitivities, and then going up to preventing symptom worsenings, being sensitive to their social isolation, recognizing the dignity and value in a person with severe ME. I often look around the room for clues about the people that they used to be. They used to play the guitar, they used to write poetry, they used to love reading, they used to walk, and all that's been stripped away from them. And finding meaning and purpose in the face of uncertainty, often just a visit is enough. Even if you can't do much to change the situation, your being there is a validation of their situation and so important. I went to Amsterdam recently and visited a mother and a daughter who both had severe ME CFS. They lay in a downstairs room, the mum and the daughter beside one another. It was darkened. They'd obviously been hugely active at some point, or at least the mum had. There were embroidery pictures and all sorts of stuff going on. And now it was really, really difficult just to talk to them. And even more sadly, the father was also unwell. When I asked the mother of the couple, did they have any dreams of what they might do when they got better, she said, yes, I have a list. And it was the first animation I'd seen. And she got out her list in Dutch, so it meant nothing to me. But she was able to translate, the top of our list is we're going to bake a cake. And that was their dream. So caring for people, I don't know how I'm doing for time. Oh, I better hurry up. Principles of care you all know about. Listening to patients, supporting activity pacing to minimize post-exertional symptom exacerbation, minimizing sensory overload, noise, smell, light, preventing infection. You might have to break up visits in order to produce an individual care plan, and be very aware of benefits, disability aids, allowances, and use the ME charities. They are great. So communicating, listening, taking adequate time to hear and interpret. So often people don't exactly tell you what they really need right away. The GP will speak about the patient at the door who says, and by the way, doctor. And you've got to listen for those signals and always validating the individual who's so socially isolated. So commitment. It's an ongoing commitment over many years, during which time the condition might worsen and can less often improve. And you should commit to offering first-class healthcare. Whatever you're doing, do it really well as you would for someone dying of cancer. I did hospice nursing. I saw people when I worked at St. Christopher's. The average lifespan was 48 hours. It was one of the first hospices. But even there, often the patients were not as ill as people I see with severe ME/CFS. This is a really serious disease. Breaking up appointments are so often cancelled, people simply aren't up to it. And remember, when you do see the patient, they're at their best. And you might need to support the patient as they embrace treatments that are really very unscientific, and only saying if you think they might be unsafe, and later when money and hope run out, continue to be there for that patient. Courage. It's the person with ME/CFS who needs the most courage for all the reasons I've said. But the healthcare professional also needs courage and determination to reach out to people with severe ME who might not want to engage, and courage during the encounters, especially when the care plan doesn't quite work out. Compassion. Remembering empathy, respect and dignity, intelligent kindness. Everyone with ME has experienced stigma, and many have tales of experiences that should never have happened. Trust needs to be rebuilt and maintained. There's no place for impatience, but plenty for empathy, respect, and dignity. So how does this pan out in practical terms? Courage enables us to do the right thing for the people we care for, to speak up when we have concerns. It means we have the personal strength and vision to innovate and to embrace new ways of working. And I think we've seen that in the earlier talks this morning. Oh, I'm sorry, was I out of sync with my slides? I do apologize. Anyway, thank you so much to my team who have been stoically behind everything I've done, and to the people who've supported us from the charities and beyond. Those are the references. But most of all, thank you to all the people who've seen me in their homes, welcomed me, shared their challenges, joys, their dreams, and their losses. It's been a real privilege.
Okay, thank you, Caroline, for this very interesting presentation. Any question for Caroline? There? Microphone. No, microphone, we don't listen.
Thank you. I just want to remind you that you wanted to say something about the biobank.
Yes, and thank you to Ella who prepared the slides, by the way. I couldn't have done that, even if I did get them out of sync. We have a biobank of samples. We have too many samples. We would like to distribute samples. There is a charge list, but everything can be negotiated. So please do speak to us if you're interested in taking samples from the biobank for your research. We have samples from over 600 people, people with ME/CFS, severe ME/CFS, MS, and healthy controls at up to 7 time points. Thank you.
There is another question there. And I have also a question.
Yeah, thank you very much for a nice presentation. I'm Rob Hust from Amsterdam, and part of the biobank that we are setting up in Amsterdam, I've been asked to take biopsies from patients who are homebound. Not particularly bedbound yet, but homebound. So all the work that you're doing essentially really prepares for this. But do you think this is feasible from your perspective to take?
Well, interestingly, Eliana did discuss biopsies with the people at focus groups before I was on board, generally people were more keen to give blood. But I think it would be good for you to discuss with Luis and Eliana. I wasn't actually at those focus groups, but the reason we went down the blood and not the muscle biopsy avenue was because that's what the participants asked us to do.
So the blood is, you would say that is relatively feasible.
Yes.
To do.
Yes, and I know they're doing that in Amsterdam because that's
exactly.
yeah.
Perfect. Yeah, thanks.
Well, Caroline, you talked about one thing I see frequently in my clinic. That's the patients who seems to do not tolerate their own sense. Light, sound, hear, touch, allodynia, of course. And also they are intolerant for many foods and drugs. All for the 5 cents are very badly tolerated by these patients. Do you have any idea about the meaning or about the physiopathology of this? But there is a very frequent issue in clinic.
All the time, yes. That's why they don't have real milk in the house, because there's intolerance.
Yeah. But we do the analysis, and they are not intolerant in the lactoses and the gluten and so on. But they don't feel like to eat or drink some. And the drugs, we have a small amount of drugs to treat those patients, and they are intolerant for many of those drugs.
Tiny doses and build up. But Luis will speak, I'm sure, about that. Will you, Luis?
Joan, one question. Okay, Luis, we are going to talk about it, but Joan has a question.
Yes, we actually have a viewing party of people who can't get out of bed in our support group, o Grupo de Apoio Encephalomyelitis and Long COVID, a WhatsApp group, and they just wanted to congratulate you on the extraordinary talk.
Oh, thank you.
And so they're all listening.
They're extraordinary people.
So thank you so much, and the team.
Thank you.
Caroline.
Thanks.
So we move on to the last speaker of the morning is Luis Nakul. Nakul is a researcher and clinician specialized in general and family medicine and public health in the UK, Canada, and Brazil. He has conducted international research on ME, CFS, and has practiced as a family physician. Luis Nakul is going to talk about considerations and challenges on delivery of care in ME, CFS, and long COVID. Luis, please.
Obrigado. Thank you. Just need to change a little bit the setup here. So just give me a moment, please. Aqui vai aqui, né? That's an opportunity for all to pace for a moment. Right, thank you very much, Joan, Dr. Vaz Carneiro, Dr. Leite, Dr. Branco, and everybody else for the opportunity that I have to share some words about the delivery of care for people with ME, CFS, and long COVID. Eu vou iniciar com um resumo em inglês e depois eu passo para o português. So my summary in English is in this graph, in this figure. Quality of services involve a functional cycle where good science is effectively translated into clinical care and policies within a system that educates, evaluates, and learns from outcomes. For that to work, we need excellent services, excellent health professionals who work with and for patients who are at the center of all. Oops. So this is important in any profession. This is important, particularly in ME, CFS, in this area. Estou passando para o português agora, mas eu vou manter os slides em inglês. E desculpa com as minhas dificuldades técnicas aqui. Mas o outline da apresentação, o resumo da apresentação, expressa o gráfico, a figura que eu acabei de mostrar para vocês. Eu vou discutir os pontos que estão aqui. Eu gostaria de iniciar com o conceito da arte da medicina. A medicina é uma arte e uma ciência. E eu quero começar pelo primeiro ponto, porque os médicos, os profissionais de saúde mais jovens, eu recomendo essa leitura. Os 10 Traits of Great Physicians. O que precisamos, e temos muitos já, claro, muitos na minha frente, são médicos e outros profissionais de saúde que saibam ouvir, comunicar, que tenham empatia, compaixão. Obrigado, André, por me explicar o sentido dessas duas palavras. E que tenham uma abordagem holística e, acima de tudo, tenham elevados princípios éticos. Essas características são fundamentais para o bom exercício da arte de saúde ou da arte da medicina. E tanto mais na área de ME e CFS, onde temos um número muito grande de pessoas, que nós chamamos de pacientes, que experienciaram negligência, que experienciaram estigma e que experienciaram tratamentos inapropriados. Se temos a arte da medicina como aliado, metade dos nossos problemas estarão resolvidos. Não é tão simples. É claro que o que alimenta fundamentalmente a prática de saúde é a ciência. Então, boa ciência é o início de tudo. Infelizmente, tivemos alguns exemplos de ciência que não prestou bom serviço ao paciente. Pesquisas de baixa qualidade, com viés de vários tipos, como de seleção, de informação e de análise e tradução dos resultados. E o Nuno e outros já falaram sobre as limitações dessa área, problemas com critérios diagnósticos e a ausência de biomarcadores. Mas vamos nos concentrar em boa ciência. E está aumentando o número de bons trabalhos científicos. Mesmo a boa ciência leva para ela ser traduzida em prática clínica e em políticas de saúde, ela demora muito. Ela é muito lenta. Esses dados de 14, 17 anos, eu acredito que são muito menos, é muito mais rápido hoje, mas não rápido o suficiente. Então, a tradução da ciência é muito importante, precisamos apressar esse processo. Os pacientes não podem esperar. Deixa eu falar medicina baseada em evidências. Fundamental para a boa prática médica, fundamental para que o conhecimento seja traduzido em práticas clínicas. Mas eu gostaria de falar uma coisa, e eu sei que tem estatísticos aqui muito competentes, eu fico um pouco temeroso de falar, mas eu vou tentar mesmo assim. Vocês estão vendo uma curva normal. Nessa curva normal, cerca de 1/3 das pessoas estão ou acima ou abaixo de um desvio padrão. E a curva normal e outros, estatística vai muito além disso, são bases de muitos testes estatísticos que nos fazem, que nos levam a tirar conclusões sobre estudos. Isso é importante, mas, na minha opinião, a curva normal, ela exclui. A curva normal é da maioria, é do normal. Normal não quer dizer normal e anormal. Normal quer dizer comum. Então, a curva normal e os testes estatísticos que existem dentro da medicina baseada em evidência, eles são muito relacionados com o fato de que as populações são homogêneas. E nós estamos aqui nos referindo a médias de resultados. Deixa eu explicar melhor o que eu estou querendo dizer. Imagina um estudo hipotético em que 30% das pessoas respondem ao tratamento e 20% não respondem. O resultado aqui é que a diferença não é significativa. Qual é a primeira reação de todo pesquisador ou toda pessoa que lê um trabalho desse? Esse tratamento não funciona, certo? Ele não funciona porque, em média, ele não foi o suficientemente melhor nas pessoas que receberam tratamento comparado com placebo. Mas deixa eu explorar esse mesmo tratamento em 2 subgrupos da população. Uma acima de não respondentes, das pessoas que não respondem ao tratamento. E o risco relativo ali é 1, não tem efeito, porque eles não respondem ao tratamento. Mas a outra metade, nesse caso dos pacientes, ou outro número de pacientes, eles têm um risco relativo de 2. Aqui, o risco relativo é de resposta ao tratamento. Ele poderia ser de meio, depende de como você está expressando. Mas existem, nesse resultado hipotético que eu mostrei, em que, de uma maneira geral, não tem resultados, existem alguns que respondem e outros que não respondem. Não importa, até certo ponto, o que o placebo, o resultado do placebo, mas isso nos indica uma coisa que é a heterogeneidade dessa doença, que alguns pacientes respondem, outros não ao tratamento. Isso que é o que acontece com MI, CFS, fadiga crônica, Covid longa, todas são doenças relacionadas e que se sobrepõem. E nós estamos aprendendo cada vez mais a reconhecer diferentes critérios diagnósticos que detectem diferentes grupos desses indivíduos. No entretanto, é importante que dentro de todos os MS, ou encefalomyelitis, todas as pessoas com encefalite miálgica, existem vários subgrupos, o mesmo para outras categorias. Então, na verdade, em outras áreas da medicina, a gente avançou já muito. Nós temos tipos diferentes de diabetes tipo 1, diabetes tipo 2 e assim por diante, vários outros tipos de diabetes. Então, ninguém vai propor um tratamento para um diabetes tipo 2 usando um estudo com uma população de diabetes tipo 1, porque a fisiopatologia é diferente, porque o resultado do tratamento é diferente. Eu só estou dando um exemplo comparativo. Só que no caso de encefalomyelitis miálgica, nós ainda não sabemos quais são todos esses subgrupos. Então, isso nos leva a considerar uma coisa que a gente chamaria de uma engenharia reversa. Como nós não sabemos quais são os subgrupos, nós fazemos um estudo e, ao concentrar nas pessoas que responderam ao tratamento, por exemplo, comparativamente com os que não responderam, isso pode sugerir subgrupos que nós podemos explorar e tentar descrever melhor. Bem, deixa eu passar para a seguinte pergunta: o que nós podemos fazer para ajudar os pacientes? E a medicina baseada em evidência, como ela foi originalmente definida, ela é incompleta, porque a ciência é dinâmica. Ela sempre será incompleta, porque nós sempre achamos alguma coisa nova. É claro que a evidence-based medicine deve ser levada em conta, mas a experiência clínica do médico, do outro profissional de saúde, e os valores e preferências dos pacientes são tão importantes quanto isso. Isso que, na minha opinião, constrói a medicina baseada na pessoa. Eu tenho 4 pontos que eu gostaria de sugerir o que pode ajudar os pacientes. O primeiro deles é saiba, conheça a evidência. A Caroline falou um pouco sobre o NICE Guidelines de 2021, e uma das conclusões principais é que existe evidência para intervenções, mas essas são, de uma maneira geral, limitadas, de baixa ou muito baixa qualidade. No entretanto, eles recomendam o manejo de energia, o pacing, como a estratégia principal para o tratamento de sintomas. Então, pacing, já foi falado hoje por outros apresentadores, o manejo de energia é essencial para o tratamento. Isso serve, de maneira geral, para toda a população. Isso é evidência populacional. Ao mesmo tempo, nas guidelines, eles se referiram a tratamentos que foram usados, mas que não são adequados para usar em escala numa escala maior. Número 2, reconheça subgrupos e indivíduos dentro do whole, né, dentro da população toda. Nós estamos falando aqui na importância da medicina estratificada e personalizada. Esses itens aqui são do Euromean, são alguns exemplos de classificação de categorias, por exemplo, grupo etário, início da doença, se for infeccioso ou não, fases da doença, severidade, Caroline falou muito sobre a gravidade da doença, os severos, e fenotipo clínico e molecular. E aqui eu vou tentar responder a pergunta que me foi dada, que foi perguntada, o que causa os sintomas? E eu acho que a pergunta foi em relação a, por exemplo, sensibilidade grande, se eu não estou me enganado, a sons, etc. Eu não tenho a resposta final, mas parece que nós estamos convergindo, a ciência está convergindo para considerar a neuroinflamação como um fenômeno central em explicar muitos dos problemas, muito da fisiopatologia e dos sintomas dos indivíduos com encefalomyelitis miálgica. Mas quando eu volto para o fenotipo clínico, a caracterização clínica do paciente, o médico, o profissional de saúde, ele vai olhar para o indivíduo e para os sintomas do indivíduo, ele pode selecionar tratamentos cujo foco seria a neuroinflamação, por exemplo, e o nosso colega italiano nos falou de algumas possibilidades, assim como a doutora Levin, em particular, mas são tratamentos muito novos, né? Mas existem outros tratamentos que servem para a neuroinflamação, ou pelo menos acreditamos que servem, que podem ser experimentados, mas também nós temos tratamentos para considerar quando o fenotipo do paciente é de desautonomia, principalmente. Quando o fenotipo do paciente é de ativação de células, de mast cells, de macrófagos, né? Ou mastócitos, desculpe. Então, o paciente os sintomas do paciente, isso tem esse paper por Komaroff, é muito interessante de como o sintoma reflete a fisiopatologia e é uma ideia de como podemos abordar o tratamento de pacientes do ponto de vista individualizado. E também temos fenotipos moleculares, como é que está a resposta imune, como é que estão os T-cells, como é que existem alterações metabólicas. Então, cada indivíduo vai ter uma apresentação diferente. A medicina personalizada nos permite fazer um tratamento que pode não dar certo, mas ele é baseado numa lógica que é bem justificada. Muito bem, eu vou tentar apressar um pouquinho. Número 3, diagnostique e comece a tratar cedo, precocemente. Isso é importante. É importante por quê? Porque na medida que quanto mais tempo de doença, quando vai dos estágios iniciais até os estados de doença bem estabelecida, com complicações, a chance de recuperação vai diminuindo. É porque os indivíduos, eles entram num estado eles perdem a hemostase inicial, eles entram em estágios cada vez mais complexos de alterações fisiopatológicas que são mais difíceis de reverter. Quanto mais precoce o tratamento, maior a chance de recuperação. Nós estamos falando de prevenção secundária aqui. Diagnóstico, pacing, e aí outras alternativas. Em vez de esperar, como muitos pacientes esperaram, 5, 10 anos para receberem essa recomendação. Então, isso é importante. E, finalmente, claro que o bom profissional de saúde deve trabalhar num serviço de saúde que seja responsivo aos problemas, às necessidades de saúde dos pacientes. E também de cada indivíduo. E que tenha uma ênfase em educação e avaliação dos resultados. Existem aqui, esse slide mostra alguns indicadores de qualidade de serviços que a maioria de vocês vai estar familiarizada, mas serviços devem ser apropriados para a população, acessíveis, inclusive para os severamente afetados cujo acesso ao serviço de saúde historicamente tem sido tão pobre. É baseado em evidências, e ele é baseado em evidências do ponto de vista populacional, mas ao mesmo tempo é baseado não só na evidência populacional, mas na evidência pessoal de cada indivíduo que se apresenta para tratamento. Eu vou mostrar rapidamente, antes que eu vá para as conclusões, um exemplo de um serviço de saúde no Canadá, na província da Colômbia Britânica, onde eu trabalhei, em que nós tivemos que nós coletamos informação de uma série de pacientes. Os resultados se referem a mais de 600 pacientes que foram tratados no serviço. Então, eu só vou explicar um pouquinho esse serviço aqui. Ele tem, existe a referência do paciente. Quando o paciente é atendido, ele é avaliado por médico e pelo interprofissional, o membro do time interprofissional, que pode ser um enfermeiro, terapeuta ocupacional, fisioterapeuta, naturopata, nutricionista, acupunturista, enfim, é um time multiprofissional. E depois disso, o paciente segue dois possíveis fluxos, o que seriam os streams. O medical stream, com tratamentos individualizados pelos médicos, durante um período de 12 meses, com follow-ups, né, com segmentos de acordo com a necessidade. E, em paralelo, eles recebem o que a gente chama aqui de group stream, ou fluxo de grupos, que é liderado pelos membros do time interprofissional, com a oferta de vários grupos. Essas são ofertas em grupos, de até 15 grupos que as pessoas podem fazer no período de 12 meses. Então, esse praticamente é o programa que é oferecido antes que o paciente receba a alta do programa. E é importante que isso é um serviço público, é um serviço não pago, é coberto pelo governo. É importante que eu ressalte que existiam, dentro desse contexto, dois problemas bastante importantes. Primeiro, que a demanda excedia a capacidade do serviço de uma maneira desproporcional. O serviço conseguia atender de 600 a 700 pessoas por ano, mas a demanda, a gente está falando em 3 zeros. São realmente milhares de pacientes. Um outro problema é que os pacientes chegavam ao serviço tardiamente. A mediana de duração da doença no momento que eles chegavam aos serviços, nessa análise, era de 11 anos, e a média de 15 anos. Então, eram pessoas que já tinham a doença há muito tempo, em média. E isso estava também relacionado não só à falta de diagnóstico na comunidade, como a longas listas de espera. Então, isso eram problemas bastante importantes. Esses são alguns resultados. As duas linhas de cima mostram sintomas, fadiga, sono, etc., etc., e com o PQ12, que é um consolidado de sintomas, que indica a severidade de sintomas de encefalomielite miálgica de uma maneira geral. Esses indicadores todos, quanto mais baixo, melhor. Então, todos tiveram uma tendência à melhora dos sintomas no período do programa. Mas só 2 foram significativos, a ansiedade e o consolidado de sintomas, o PQ12. E embaixo são indicadores do SF36 de saúde mental, que melhorou. Esses indicadores, quanto mais alto, quanto maior o score, melhor. E a saúde física, que também melhorou. Esses 2 resultados foram significativos. Então, teve uma tendência, teve um melhoramento, uma melhora dos sintomas de uma maneira geral, mas os resultados foram modestos. E a maior razão que nós interpretamos que foram modestos é pelo fato de que os pacientes chegaram muito tardiamente no serviço. Então, isso é uma solução que foi proposta, e isso é uma solução que eu acho que serve para serviços públicos, a maioria dos serviços públicos, onde quer que estivemos. Nós sim precisamos de um serviço especializado. O Euromini, por exemplo, recomendaria um serviço para cada 10 milhões de pessoas. É perfeito para Portugal. Não foi pensado em Portugal, mas deu perfeito. Então, temos que ter um serviço central. Mas isso não é suficiente, porque a demanda sempre vai ser grande. Então, o que nós precisamos também é que o atendimento inicie e continue dentro da saúde primária, dentro dos cuidados de saúde primárias. E, potencialmente, nós podemos ter também serviços que a gente chama de clínicas satélites nesse gráfico, que representam serviços de média complexidade. Esse seria um modelo que permitiria que os pacientes sejam vistos logo, reconhecido diagnóstico logo, e a intervenção começa, mesmo que a nível primário, mas começa precocemente. E os serviços especializados teriam uma função de dar apoio aos serviços periféricos e, ao mesmo tempo, lidar com os casos mais complexos. É claro que isso é difícil de implementar e uma das razões é o treinamento dos profissionais ainda está abaixo do que gostaríamos. Então, o treinamento e a educação de profissionais de saúde é essencial para que isso funcione. Esse estudo foi corroborado, foi confirmado por estudos qualitativos que fizemos junto com pacientes, isso também no mesmo local no Canadá, na província da Colômbia Britânica. E veja só como os pacientes nos disseram a mesma coisa. Primeiro, que existe um isolamento social profundo, que existe um estigma profundo, e que é difícil receber diagnóstico e receber tratamento. Então, essa é a realidade que os pacientes nos transmitiram nessa pesquisa. E quais são as soluções? Eles também indicaram as soluções, o que precisa. Precisamos de mais educação em MR, exatamente o que nós precisamos fazer, não só com os profissionais de saúde, muito importante, mas também com o público em geral e com os pacientes. E também eles indicaram a necessidade de melhores pathways de saúde, melhores fluxos de saúde, o que pode ser conseguido com um serviço de saúde primário forte, funcionante e integrado com serviços secundários e terciários. Ninguém reclamou do tempo ainda, então eu continuei falando, mas eu vou acabar agora. Eu vou acabar em 2 minutinhos. Eu só queria lembrar para vocês que existe um ciclo um ciclo de excelência de saúde pública, de serviços públicos. Ele depende de boa ciência, ele depende de qualidade de serviços e depende de educação e avaliação do que você está fazendo e uma constante descoberta do que, né, do que você está fazendo e dos fracassos e dos sucessos, e isso realimenta o ciclo. E é muito importante que nós precisamos de excelentes profissionais. Como disse William Osler, um médico canadiano, listen to your patient, he's telling the diagnosis. Ouça seu paciente, ele está dizendo o diagnóstico. Muito mais que isso, na verdade. E também, os grandes médicos, eles tratam o paciente, não a doença. Esses são 2 exemplos do que significa a arte da medicina. Ainda tem um caminho muito longo para chegar lá, mas eu acho que tem maneiras eu acho que, assim, eu fico otimista que existem avanços na ciência e eu acho que tem oportunidade de avançar os serviços públicos de saúde. Obrigado.
Thank you, Luis, for this interesting presentation. Now, Nuno, we have a question for Luis. We have still time.
Okay.
What? I don't know. I have the questions here, but I don't know if Danilo is still there. Danilo? they were for Danilo. It was related with children, so I don't know if anyone in the room is able to. Como? Okay. So, Caroline, maybe we can sit here. Wish.
Jean, can I ask a question or no?
Thank you. Any question from the floor? Okay, Nuno.
This question is to Luis, and first of all, I would like to thank you for the wonderful presentation, because I always learn something from you, because I'm a mathematician and you're a doctor. I love your slides. And in one of your slides, you said something about a lengthy diagnosis, right? And when we were in Euromean and we were discussing the case definitions that would be recommended in Europe, I was just wondering, the length of the diagnosis can have two causes, right? The one part is actually the disease recognition is low. And the second one that is not so well discussed is the exclusion criteria that you have to do it to have the diagnosis. From your perspective, and that's my question, is would you believe that would help not to have the exclusion criteria and you have like suspected chronic fatigue syndrome, and then along the way you actually make a strong case towards that? I think maybe this accelerates the diagnosis, but I would love to hear your thoughts about that.
Yeah, I totally agree with you. The NICE guidelines is interesting. They change from the IOM in two senses. One, you don't need to wait 6 months for diagnosis, but 3. But more than that, with 6 weeks in adults, in 4 weeks in children, you can suspect a diagnosis. And I'll tell you, as a GP, GPs are not very good at saying you have something. They like to observe the patient for some time until there is a confirmation. So the idea of suspected diagnosis, I think it's very important. And this can facilitate early recognition. The other aspect is about case definition. And I think it's very important that we distinguish research definitions from case definitions. Research definitions need to be very specific, because we don't want to muddle the waters, and then we want results that are reliable. But clinical diagnosis, they don't need to be that specific. So they recognize that people may have comorbidities, and if you're unsure about the diagnosis, you need to treat the patient is there anyway, so you can deal even if the diagnosis is not a formal one of ME, for example, or something else. So I think that we can be more relaxed in accepting the patient for clinical treatment. I think, Nuno, do you have a follow-up question or?
No, just a comment on what you said. It's something about research and clinical. Well, you do recruitment through the clinic, so in a way you need to have some kind of agreement between the two. Otherwise, you take like I'm coming from the infectious disease, tropical disease mostly, and you have convenient sampling. And by doing, recruitment via like a case definition that doesn't have like exclusionary criteria, then you ended up with a cohort of patients that you would like to recruit for research, but they actually don't comply. So how would you do that? It's just
right. Briefly, well, not all patients in clinic will be eligible for research. So research can be more stringent for acceptance to research. But there is something else that the IOM has, the NICE guidelines have, is that differential diagnosis has replaced exclusion criteria. Differential diagnosis needs good clinicians who look at a patient, do a good history, physical examination, tests as needed. And this will enable them to come to answer the question, is this really ME or could something else? So there is this idea of exclusion is less used in clinic. It's more used in research, because in research you want to be very, very algorithm-like, if that makes sense.
There is another question. Okay.
Hi, good afternoon. Yes, good afternoon. Following up from the question from, sorry, I forgot your name, sorry.
Caroline?
One of them, as a carer of someone that suffers from ME CFS, and the common on all the groups that we're in, one of the big delays comes from the lack of recognition that the person is sick, and it gets parked and thrown onto its anxiety, it's psychiatric, and we don't listen to the patients. And again, my experience is the patients know what they're feeling. A sick patient does not pretend to be sick. And we need to listen to the patients because they know what they're feeling. Even I, as a carer, cannot really say what the person I care for feels. We need to listen. And think that alone will diminish by more than half, if not even more, that we start attending to to care the patient, start early if we listen. And if we make a mistake because we listen, that mistake will still be shorter lived than a person with MS taking 7 years to be recognized. A person with any CFS taking 20 years to be recognized and to be helped. And I don't know what we can teach the younger doctors that are coming in, that they listen, and what we can do to the older doctors, that they pay attention, listen to your patient. They're not psychiatric cases, they are ill. And this is for families, this is for long-term friends of the patients. They already have such a burden. We need to listen to them. Thank you.
Yes, I mean, I totally agree. And I thought that was changing. Years ago, we were told to listen to mums about their children because the mum knew the child wasn't well, and you were at your peril if you didn't. And I just think we don't learn, do we? And I think listening takes concentration, it takes time, it can't be hurried. And I think that's what people deserve.
Well, I have here one question about, I don't know if there are anyone in the room with experience on that. Which nutrients can you have more benefits on EM-CSF patients on the practice? I have no experience with that in clinic. Well, what I know about it is that caffeine, tea, coffee, and tobacco and chocolate must be avoided in the afternoon because they pressurize the sleep. And I don't know much more than this in terms of nutrients for the treatment of these entities. So you have another question?
Yeah.
For you?
My question is how to get more severely affected patients into clinical trials. Aha. Well, we're writing a paper. But in broad terms, funding and endless patience. So the funding is important because you have to be able to go to the patient, and that's expensive. So you have to build that into your research grant. You have to build in the amount of time it will take. You have to build in, I particularly have to build in the time it takes to get the samples back to the hospital in London where they're processed and stored. So the NIH historically have been incredibly generous to our project because it costs a lot of money. And then as an individual, and Ella helps me hugely with this, you're trying to make an appointment with someone who can't speak on the telephone, doesn't want to speak on the telephone but can't. They might go onto their phone, their mobile, intermittently. So you might text and get a response 3 days later. So actually setting up the appointments, you need you need a lot of time, so that has to be paid for, and a lot of patience. And you must never get exasperated because people don't mean to cancel the appointment you've made all these arrangements for at the very last minute, but they're just not well enough to go through with it. So I think those are the two important things, the funding and the time and patience. People who have ME are so wanting to take part in studies, particularly the severely affected, because they know how few people do take part. So that's not an issue. And they use a lot of social media. So if you're looking for people to take part in trials and studies, then social media is the way to go.
Thank you, Caroline.
Right, this question, many patients are being recommended alternative treatments like acupuncture and Perrine technique, for which there is no evidence and are often provided by private practitioners. What do you recommend as best practices in these circumstances? That's a good and difficult question. What I would say is that we offer acupuncture in that service in Canada, and many patients were pleased to receive the treatment. But I can't tell you if this was because it was really effective or if the caring that the professional shows to the patient matters the most, and people like that. I don't think there is, I mean, I cannot say A or B, do or don't do. What I can say, I think the patients are entitled to have an opinion, are entitled to discuss with doctor. I would like to try this one. And on an individual level, I think the doctor can have an open conversation with the patient and make a joint decision about that. Sometimes the decision will be, well, try this one and see what happens. And then if it doesn't work, you stop, and then you can try something else. So I think in the world of little evidence, I think that especially the safe forms of treatment, and some are safer than other treatments, I think there should be some flexibility. Unfortunately, in the private sector, this is not difficult to organize. In the public sector, depending on where you are, it's a little bit more difficult to be able to offer treatments which are not evidence-based. And this is a reality that we need to accept and try to change, of course.
Could you speak to the parent technique, please? The parent technique. Parent technique. The parent technique.
Well,
I know many words, but I didn't know enough about it.
I know the guy, and I think I cannot comment on treatment. It's beyond my. It's an alternative form of therapy, and I mean I don't feel that I can comment on that. He's a good guy, though, I think.
Yeah.
Thank you. There are two questions which can be answered maybe together. We have just heard detailed presentations on therapeutic strategies and coordinated care models in ME, CSF, and long COVID from the United States, Italy, and UK, where multidisciplinary clinics as structured pathways already exist. In Portugal, however, there are still no defined clinical pathways or coordinated care programs for these post-viral conditions. Given what you have learned today about best international practice, what are the realistic next steps to establish a coordinated care model in Portugal, and how should lead that process? That process. Should it be hospital-based, university-driven, or supported by the Ministry of Health? It's a very difficult question and very difficult answer. The second question related with it is how to incentivize health professionals to educate themselves according and be adequately capacitated for these patients. How to make that education a public policy and not only a personal choice. I think the answer in Portugal must be a centered process and centered initiative from or the Ministry of Health or from the Direção-Geral da Saúde. It is very difficult to do it in another way. Of course, it must be based on in family doctors and the reference for one or two specialized centers on complex diseases, as Luis talked about in his presentation, is a need. But if the initiative is not central, it's very difficult to provide the correct care for those patients. And included in that is the formation, is the training and the education of medical doctors and the other professionals for care of these patients. I think we must do the pressure necessary and I think it's best, the better way is to talk with the Diretora-Geral da Saúde. So I think I have another question, and I don't know if from the floor. Okay. So there, Nuno. Excuse me, but there are. Okay, please go.
I just wanted to follow up on some comments that were made earlier about. My name is Betsy Keller, by the way, and I've been doing the 2-day cardiopulmonary test for a long time. And I wanted to comment on some of the statements that were made earlier about listening to people with ME and long COVID and their symptoms. I think that there's something else that you can add to that mix when you have a patient coming to a practice, and those are the more subtle acknowledgements that they have environmental hypersensitivities oftentimes, so keeping the lights low in the environment, bringing them into a waiting area that's not busy and not noisy, moving them out of a waiting area as quickly as possible into a room where they can lie down or at least sit down. And when you do that early on, oftentimes they're surprised and they understand that you understand. And those are not things that take up a lot of time. They can be done pretty quickly. Right off the bat, but also just want to reiterate how important it is to be able to confirm for someone who feels terrible, and they have for a long time, that despite the fact that you want to tell them, you don't want to tell them that they had an abnormal response to exercise. I can't tell you the number of times where patients have asked me to go out and talk to their family to confirm that their exercise test results are indeed abnormal, and there's a reason for why they feel that the way that they do.
I agree with you. I mean, I don't have a specific expertise in environmental medicine, but I would refer early to the experts in environmental medicine and there's a very good clinic in Toronto, in Canada, for example, to do further investigations. I think you need to look at multiple potential causes, and of course, environmental challenges. They will be noticed by the immune system, and this can help perpetuate or even initiate illness?
Hi. So I'm Anna, and I'm a family physician and also a long COVID patient. So I've been on both sides of the coin, and I'm having that, at least here in Portugal, I don't know if it happens in the other countries. I think one of the major problems in the diagnosis is that physicians don't know anything about this condition. So we learn nothing about it at university. There's no knowledge about the disease, and as I was saying to my colleague, you can't diagnose a disease you don't know exists. You can't think about a disease when those symptoms don't make any sense to you. So I think there's a huge gap in education, and I think it can start at universities, but we have to teach also physicians that have a lot of years of experience. They still don't know this exists, they don't value. And then it happens that patients say that physicians don't listen to patients. I think, of course, it happens. Physicians don't listen to patients. They have little time, but also if you don't have the knowledge, you won't think about it. So I think that's, I don't know, maybe the JS, maybe the ministry can start some learning programs or some sort of updating, but it's difficult. I think it's very difficult, but if we don't start at the base of the pyramid, and I loved your presentations about the way things work in UK and how everything is well structured. Here in Portugal, actually, you have a quite organized national health system, and I think primary care works pretty well for a country with little means. But I think we have a good integration with the secondary care. I work on a unit that has worked well in that area, but if primary care doesn't know anything about this disease, patients won't get treatment. Patients won't be properly treated, and disease will get worse. So I think this is a huge thing that needs to be attended.
Well, I fully agree with you, but if, as you said, you have two hats, the patient and the doctor, medical doctor, and so I think medical doctors are trained for having success in their practice, so they avoid the unsuccess. And with those patients, we have many unsuccess in our consultations and in clinics, and medical doctors avoid that, as other professionals in their profession. I think this is also a problem, to train doctors to have some cases who are not successful, and this is part of life. But we are not trained for that in medical schools, and I know what I say.
But I think family physicians are quite used to unsuccessful treatments.
Yeah,
I think,
I know it because I do it, but the question is that many of those cases are not, because you are all right, the knowledge of these pathologies is not so good for the...
Yeah, I agree with you. I think physicians don't like the unknown and don't like things they can't understand properly. and things that don't have a lot of evidence. That's all true. But I think family physicians are quite used to uncertainty and are quite used to having the patients, even if you can't offer curative treatment, you still have to support them. You have patients since they are born till they'll die. So we are used to not being.
We can be useful in many
yeah.
ways, of course.
But
we must
people,
have time also.
Yeah. Yes. That's a huge problem. I always worked at NHS, and we have a huge list of patients and a lot to attend. So we do preventive medicine and curative, and sometimes the time to listen properly to the patients is very limited. So it's difficult. But I think we have to really focus on educate the physicians, because I think post-infectious diseases weren't taught at all when we were students.
Thank you. Bruno.
Just to connect, and I think Iliana's, Luis' talk and Caroline's talk, I'm just wondering about severe patients. Why don't you trying to consider a phase 1 clinical trial only on severe patients, and then connected with the, let's say, average-based evidence? So if you are in phase 1, I think you don't need a lot of statistics, and that's the kind of change in how you report the results. And I'm a statistician by training, but we over-rely on p-values and significance on average effects. And I think if you go towards like a phase 1 clinical trial on severe patients, I think it's more manageable, and actually it's easier to fund because the sample size is smaller. So what do you think about that? So.
Well, yeah. Well, I agree with you, but it's challenging logistically to do severely affected trials. Severely affected. Caroline was talking about you need to go to the home to the patients. They are expensive, so there is a funding limitation there, a funding difficulty. But I totally agree with you. Let's design in severely affected and hope we can get some money.
We only have time for one short question. One short question. I'm pressed by the organization, so one short question. One. No, there are. Okay. In the afternoon, we have time to do more.
I can just speak. Yeah? Okay. Hi, my name is Niels. I am a long COVID patient, and I just had a follow-up question. You were speaking about, that there's no official pathway, clinical pathway for long COVID and ME CFS patients in Portugal. And I just wonder if you have any insight as to why there isn't one. Because if you look at, the UK and the Netherlands, 2 countries I happen to be familiar with. I know there are specialized long COVID clinics there. My experience with them has been varied, but still, it exists. So do you think that this is a lack of willingness, a lack of funds, or just a lack of awareness amongst decision makers?
It's a bit of a myth about the wonderful care pathways we have in the UK, because I have to tell you that most people are tearing their hair out.
No, I mean, I have experience with it. I know it's not great, but at least there is one.
There is one, yeah, but it needs a lot of work.
Yeah, agreed.
I think maybe in Portugal there's a real advantage in starting from almost, and not nothing, but almost nothing, because you can look at best practice and you can try to build up, doing it in, you know, in tandem with people who have the disease, so that also guides how the clinics are set up. And I think you've got a real opportunity here that perhaps we've lost in places like the UK.
Yeah, I just wonder why, you know, decision makers don't seem to necessarily, you know, be acting on this, at least in Portugal.
Okay. So, okay, I'm pressed. So we are going to lunch, and in the afternoon we can maybe have more, just have a discussion about the questions you have. Thank you.
Thank you for what you are doing.
Sim. Sim. Sim.
Nice to be here with you. And I'm supposed to do something which is presenting our next speaker, which is Dr. Chris Ponting, okay? And his interest in myalgic encephalomyelitis grew from participation in the UK ME research collaboration, MERC, formerly known as the CFS ME Research Collaborative on CMRC. The DecodeME project evolved in 2018-2019 in a process during which PPI was embedded in every discussion and workshop, resulting in a full presentation production. He was the chief investigator of DecodeME and one of three individuals on its management group. The project was the world's largest ME CFS study with 27,000 UK-based participants, of whom approximately 13,000 contributed to the saliva DNA sample. And this was a very complex but very central study. Chris Ponting will be talking about, sorry, I didn't bring the, okay, so I'm not sure. Hello, Dr. Ponting. Hello. Hello, Dr. Ponting, can you hear us?
Hello from Scotland.
We can see you and hear you. So the floor is yours. I just made your presentation. Thank you very much for joining us. The floor is yours. Thank you.
Thank you, and I hope that you can see my slides. Right, I'll take that as a yes.
Yes, we can.
Brilliant. That's excellent. So I'm delighted to be with you in virtually any way today. Hope you enjoyed your lunch. Thank you so much for the privilege of speaking to you today, and thank you for allowing me to do so virtually. Today, I'm going to talk to you about the first results we have from the genetics DecodeME project, funded in the UK by the Medical Research Council and the National Institute for Health and Care Research. It was a co-production, as we just heard, and that was critical, in my view, for the success of the project. So I'm going to talk to you about why we looked at genetics in the first place, the process by which we got to the current state of results, the results themselves and what they mean, and what, in my view, should come next. So the main reason, in my view, why genetics is really important is to ensure that pharmaceutical companies in the future have sufficient evidence to hand for them to be confident to invest their funds on ME/CFS drugs and drug trials. They should be convinced by genetics. And I note here that 2/3 or so of FDA approvals have genetic support, and 92% of these have genetic support before approval. And so in this recent article, it was said that 40 target or 6% of FDA approved drugs required genetics for the approval. So it's really important that we look forward to what I hope will happen and happen soon, which is that there are trials for interventions. The second thing why we do genetics is, and we look across the whole genome and all the genes, is that it's essentially unbiased and secondly comprehensive. And this is important because it may yet be determined that what's going wrong in people with ME is not rooted in known biology, but rather in unknown biology. And so if we stick only to known biology, then we would be overlooking the importance of various biological processes. And when a comprehensive approach is undertaken, then essentially the genetic can pinpoint what bodily system is implicated, whether it's the nervous system or the immune system or anything else. And that's important for ME, as we all know in the room that you're in. Everyone knows that there are very diverse symptoms of ME, and so this question of relevant bodily system is not yet confirmed. So how have we got to where we are? It's a project that has been going on for 5 years and more, and there were and are 3 objectives. First of all, we wanted to identify genetic differences that are statistically different in people with ME relative to population controls. And this would begin to explain biological mechanisms behind the disease. What we did not say at this point in time was that it would immediately lead to therapies and diagnostics. Secondly, we wanted to build a well-defined cohort of people with ME for future research, not really for us, but for everyone else. And so our cohort has been asked to consent, and the vast majority of people have consented to be recontacted for future research, and secondly, for their data to be shared at the individual level with other researchers around the world in academia and or in industry. And that's the third objective, that we disseminate the data, and so that there will be outcomes from our study that were completely unanticipated. Now, the important thing that I've learned over this project is how important it was that we co-produced this project with people with ME. We understood their lived experience. They contributed greatly to the design of the questionnaire and how we discussed matters online with individuals and led many aspects of the project. Our recruitment was based on people who are 16 years or above with a clinical diagnosis of ME by a healthcare professional and people who lived in the UK only. And there's a very simple approach to what we've done, is to look at around about 500,000 places across our chromosomes and ask whether DNA variants, DNA letters, occur statistically significantly more frequently in people with ME over the population control. And if so, then what happens is that we draw a plot, which is here in the bottom right. This is not the real data, and the data points rise up above a horizontal line to generate what is called a Manhattan plot, and wherever these dots appear above the line, that is a genetic signal that is reported. So the key principles of co-production is that we share power, the research is jointly owned, and we work together. We include all perspectives, and we make sure that the research team includes all those who can make a contribution. We respect and value the knowledge of those who work together. Everyone is of equal importance. And there is reciprocity. There is not just a benefit to those who are researchers, but also those who are not. And that building of and maintaining of relationships is key to the sharing of power. And because there is a need to be joint understanding and consensus and clarity over roles and responsibilities, and important to value people and unlock their potential. So that's the key principles and values that we held to in this project. So I'm just going to, before showing some of the results, just show those who contributed to the delivery of the DecodeME project as listed in the preprint. And on the right was our original study protocol document. So, as I said, there were many people who signed up to the DecodeME project. 27,000 or so completed the questionnaire. 21 or 22,000 met eligibility criteria and were sent a saliva collection kit. And then an enormous proportion, 85% of people returned their kit, demonstrating the desire of people to contribute to research. DNA was extracted, their DNA letters read out and passed quality control for the vast majority of them. And the results that we've reported are those people of European ancestry. We would wish to analyze everyone's DNA, and indeed we're continuing to do so, but it's also important, very important, to match genetic ancestry between cases and controls. Otherwise, we would have come up with false discoveries. So that's why we did that. The cases that were defined are approximately equivalent in age, bottom left, and comorbidities, bottom right, with people who have an ME diagnosis, a G93.3 code in England. And so we believe that the cohort is fairly representative of the entire population of people with ME in the United Kingdom. The only exception is there is a substantial difference in the proportion of people reporting irritable bowel syndrome as a comorbidity. We also have responses from 15,000 people on a questionnaire 2, which includes their assessment as to whether particular treatments are positive or negative for their symptoms, and we'll be reporting on that as soon as we can. But suffice to say, unfortunately, there was not a single treatment that was very positively received by very many people. On the other hand, there were several treatments that were reported very negatively, especially graded exercise therapy. So here are the results that we pre-printed on August the 6th this year. There are 8 signals that we reported in a variety of the analyses. Here, 6 of them are reported from one of the GWASs, the genome-wide association studies, GWAS1. So again, what you're supposed to take away from this plot, this Manhattan plot, is that every dot represents a DNA letter, and we're testing to see whether they are frequently different in their frequencies between cases and controls. And if they are significantly different, then those dots rise above this horizontal line. So what we've done here is to annotate the genetic signals by genes that lie nearby to those signals, and you'll see that they occur on a variety of different chromosomes across the whole genome. We haven't yet reported on the X chromosome. So there were 8 regions that are statistically associated with ME status across the 4 studies that we presented there. And there will be evidence that I'll show you in a minute to say that they are relevant to the nervous system, the CNS, and the immune system. We found no evidence whatsoever that there was any sex bias in the genetic associations. We did test, but there was no statistical evidence for that. And 4 of the 8 signals did have statistical replication in data from national biobanks, but these associations were quite modest. So we were pleased to see that, but they weren't as strong as we would have hoped. So to do with the nervous system involvement, the study here was that we used an algorithm called MAGMA, which essentially looks at whether the activity of genes that occur in these genetic signals are more likely to occur in particular parts of the body. And I think there were about 55 or so different parts of the body that were tested, and 13 came out as significant, and all 13 of these were brain tissues. So what this does is to say that it is highly likely that there is nervous system involvement in the genetic risk factors of ME/CFS. So here's one example on chromosome 17, one of the 8 signals. This lies the signal, which is, as you see, the data points in triangles that lie above the horizontal line. This signal is just to one side of a gene called CA10. And what was really interesting for us here is that exactly the same signal was found in a different study, not a study of ME, but a study of chronic pain. So what has happened here is that the genetics of ME is speaking back to us as researchers of the chronic pain that people often report in ME. And so that closed the circle, really, and began to explain the genetics of some of the symptoms of ME. There is, we believe, an immune system involvement, and I'm showing on the right-hand side 2 signals that likely relates to the ability of people to respond well to infection. So on the top is a region of chromosome 6, which had a large signal between some histone genes, the H genes on the left, and the B genes, or tyrosine genes, on the right. And we believe that it may rely on the regulation of this gene here, BTN2A1, and our belief on that comes from a new observation that it is this gene that appears to have the most significant burden of rare variants that are deleterious among all genes in the genome, using UK Biobank AstraZeneca results. On the bottom right is another region of the genome on 13, where there is another signal. And this was very strong among people who had reported an infection just prior to onset, and is just next to a gene, OLFM4, whose function is in neutrophils in dampening down the innate immune system after infection. And I should have said the butyrophilins work as a sensor of bacterial infection. However, the DecodeME results do not immediately implicate single genes. What we have to do, and this is done in all such studies, is to use other data to implicate single genes, to prioritize them. And the way that we do this is to ask whether the ME genetic signal, which we're indicating here on the top line, is overlapping the genetic signal for a gene's expression, its activity. And if they do overlie one another, they superimpose, then they do something called co-localization. They are co-localized, and that provides additional evidence that it is the gene that contributes to any genetic risk. So what we've done is to look at all of the genes in all of the 8 regions and use all of the expression data that's available from a resource called GTEC, and ask ourselves, indeed, whether the genetic signal for ME co-localizes with the genetic signal for gene activity. And where that co-localization happens, it is represented by larger circles here, the genes on the y-axis and the tissues on the x-axis. Green is where ME/CFS genetic risk is positively correlated with gene expression, whereas blue indicates where increased risk is associated with less gene activity, less gene expression. And we can also play this trick not only with genetic activity, but we can ask whether the genetic signals of one trait, here ME, co-localize or coincide with another, as we did previously with the CA10 chromosome 17 example. And so we were thereby able to come to the conclusion that there was no evidence for co-localization of ME genetic signals with any other human disease trait like major depressive disorder, except for the chronic pain example that I've already discussed. So this is the chronic pain example where essentially the DecodeME genetic signal in green co-localizes with the multi-site chronic pain signal. And we've plotted them on the same x-axis scale. So what are the implications of these initial results? The main implication is that genes do contribute one part of the puzzle. But what it doesn't say is that if people have these genetic differences, that they definitely have ME. It also doesn't say if they don't have genetic difference, that they won't get ME. And that's because DecodeME has only found a very small subset of all of the genetic risk factors that have yet to be found. And what we have tried to message from this project all the way through is that the project's results would not immediately lead to a treatment and testing. Rather, it would kickstart and accelerate future research, narrowing down what are the genes that, and their variation that contributes to ME and how, and also to focus our minds in the field to how we can accelerate towards those effective treatments and diagnostics. There is more to come. We are continuing our analyses. We haven't yet sent any manuscript to a journal. We're doing gene-specific work on using something called GATE. We've done some dominance GWAS, if people know what they are. And we've recently produced our final HLA results from associations in chromosome 6. We have done this analysis to compare with genes that carry a burden of rare deleterious variants. And we, in collaboration, are doing some more fine mapping. And we are carrying on our pledge to do more work on chromosome X, the mitochondrial genome, and potentially structural variants in the future. It was very heartening to see in work that was preprinted after ours that fibromyalgia as a risk was found to have genetic overlap with ME at two loci, the OLFM4 locus that I presented earlier and the RABGAP1L locus. So essentially, some of what we have found replicates in a comorbid condition. And others, particularly people from Precision Life, have already identified overlap in the genes between long COVID and ME. So essentially what we have here is evidence for shared genetics among infection-associated and other chronic illnesses. They are not going to overlap completely, but there is indeed overlap in their genetics. As I said earlier, there is a data sharing process. It's all online. Happy also to talk to people individually. If you want the data, you apply for it. It goes to a data access committee, including independent members. Most applications are successful and data is shared. So what next in our view? Well, one of the things we would love to do is to take advantage of the 18,000 or so DNA samples that we have still in our freezers, and not just read out 500,000 places in our genomes, but all 3 billion places in our genomes. That's whole genome sequencing. That's an extraordinarily ambitious goal because it's very expensive. Would cost, for example, of the order of £20 million. Nevertheless, we do believe it has substantial benefits. And so we have teamed up with long-read technology leaders, Oxford Nanopore Technologies, again, the Charity Action for ME, and colleagues at EMBL EBI near Cambridge to plan this study in the hope that ultimately it will be funded. And that is because we believe that rare DNA variants will be able to shortcut the process to finding mechanisms of disease and effective treatments. And only rare DNA variants can be studied using sequencing and not the DecodeME approach previously. And ultimately, this same approach, this whole genome sequencing long read approach, can read out larger changes that are structural rather than point. And the same technology can read out DNA methylation. So we can answer these questions if we were to have whole genome sequencing using long reads of thousands and thousands of cases and compare them with available controls. So thank you so much for your time and the kind invitation to come and speak with you today. And I hope you're having a lovely time there in Porto.
Thank you, Dr. Ponting. If that's all right with you, we'll have a couple of questions from the audience. Please raise your hand.
Hi,
One first,
thank
and then
you, Dr. Ponting, for the really nice overview. I had two somewhat related but hopefully quick questions. The first one being, with the mutations that you got, or I guess with the differences that you're seeing in the genome, naturally that should lead to some sort of mutation functionally in a protein thereafter. So have you, or can you speculate on what those outcomes might be? Like, are these null mutations, hyperactivations?
So I'll answer that question first. So these are not known mutations. They're not known to affect any other human trait or disease apart from the chronic pain example I showed. They are not also of large effect. Rather, they are of very small effect. And it could be argued that their small effect means that they're not important. But that is not the case. And that is because even though they will have small effect, when you can intervene, ultimately, pharmaceutically, you can have major effect, a large effect. So even though these might pinpoint the regulation of the abundance of proteins, which is what we believe, in only a small way, if later on pharmaceutically you can knock down the whole protein or inhibit its function, that in theoretical terms would more likely be effective.
And if I might just follow up with that as well, there's been some interest in doing RNA sequencing or looking at those particular proteins that might be related to those DNA changes. Could you also maybe talk about how these certain mutations might then influence things like RNA sequencing?
Yeah, thank you. And one of the principles that we used for trying to determine which of the we prioritize is absolutely using RNA sequencing from the GTEC project across all of the different tissues. So we've already used that, the genetics of gene expression, to try and prioritize genes. But I'd like to say one further thing, and that is among all genes that are differentially abundant in mRNA or protein, some of those, probably most of those differences between cases, ME cases and controls, could be downstream of the cause of disease because of people's understandable inactivity or their drugs or other factors. And so when people we find in our studies differences in molecular abundance, they need not immediately suggest to us that they represent the ultimate cause of ME pathogenesis.
Okay, we have already the two last questions. Yours first, and then I have an online one. Sorry, we are running late. That's why I'm being.
Hello, Professor Pontin. It's Rowan Gardner from Precision Life. Thank you very much for mentioning our work. Chris, you talked about the importance of co-creation of the data. Can you talk a little bit about how we continue to measure how well the participants in DecodeME are involved, inspired, enjoy participating in the research, and what your plans are in that area?
Thank you, Rowan. I hope you're enjoying your time there. We just had a meeting with Precision Life just an hour ago, which I very much enjoyed. Your question is about co-creation and co-production. One way we measure the satisfaction of people contributing to DecodeME is the rate at which people have withdrawn from the study. And that is a very small proportion, and it happens in all studies. There have also been a large number of, relatively large number of people who have changed their consent to allow their data to be shared with others because they've understood, we believe, the value of this study ultimately. There is a paper being written, not by me, but by the PPI members of DecodeME to explain their views as to the benefit value that has emerged from the way in which we have co-produced this project.
Right, thank you. Dr. Ponti, one final question. Does the study eliminate the possibility that the nervous system genes are affected by the illness itself? Thank you.
Thank you. So no, we're not able to demonstrate the negative in that regard. What we have looked for is whether the genetics of ME and the genetics of all other diseases that we've looked at, including those of the central nervous system, can be explained in exactly the same way genetically. And the answer thus far has been no. So no genetic overlap between ME and other diseases such as major depression. But what we can't say is that there is reverse causation or complicated interaction between genes and our environment, because ultimately that will have happened, and we think that because it has happened in many diseases.
Thank you, Dr. Ponting, and thank you once again for accepting to talk with us today.
It's
Bye-bye.
a privilege.
Thank you.
Thank you very much.
Let's move on. We shall moving on now to the early career panel, and I'm calling to the stand Dr. Mário Santos. Mário Santos is a clinician. Oh, okay. All right. I didn't have that information. Can you present yourself?
Yeah.
Thank
sure.
you. Thanks.
Good afternoon, everybody. So I'm not Mário Santos. Unfortunately, he's got a flu and is not here. I'm a pulmonologist and also a sleep medicine specialist. So I'm basically a clinician. I'm very delighted to present this early career panel. And the first one is João Malato. I've noticed that the panel is quite different. So we have from both sides of the Atlantic. So exercise biologist. We also have a medical doctor from here from Porto, and we have also a biologist from South Africa. So we got a very interesting group of people here. So without further delay, I present João Malato, who is a computational biologist from Lisbon. He's working in Gulbenkian Institute for Molecular Medicine. So João will talk about why ME CFS research is statistically challenging. Thank you, João.
Okay, so sorry, let me just set everything up. hopefully, so is it sharing? Okay, so thank you for introducing me. Thank you to the organizing committee, and thank you to Joan for inviting me and allowing me to speak. So hi, I'm João. I'm a researcher here in Portugal, and I work with ME/CFS and Long COVID, but I'm a biostatistician. So I'm going to present my side of the story a little bit more detached from the actual working with the patient. So it's more on a not meta-analytic side, but keep in mind that this is my perspective. Is it working? Okay. So I'm going to speak about how doing research in ME/CFS is a statistical challenge. So we all know that ME/CFS is a complex disease, and this is due to the absence of candidate biomarkers to objectively identify the disease, leaving clinicians to having to perform their diagnosis through, as Louise mentioned, symptom-based assessment criteria, physical exams, case history, and excluding for any other conditions that might result in similar symptoms. And the figure that I'm showing is that there are multiple unique, I'm sorry, this is just shifting. There are multiple unique symptom-based criteria to diagnose ME/CFS, which is the same as saying that there are unique case or unique definitions for this same disease, and this creates a challenge when we try to replicate other studies and replicate the results from other researchers. And I first experienced this and got ideas on this impact of how impactful this is in the replicability of ME/CFS research when I worked with Eliana and Luis at analyzing their UK ME/CFS biobank data, where we try to define the, sorry, this is actually, so we tried to compare the profile of severity of different symptoms ranging from absent to mild, moderate, and severe, and compared this profile of severity between ME/CFS patients, healthy controls, and chronic fatigue, but not chronic fatigue syndrome diagnosed patients. And our results are plotted here in a multidimensional scaling plot. And we found out that we were able to discern in between healthy controls and ME/CFS patients, where healthy controls usually have less severe or a majority of absence of symptoms, sorry, and where ME/CFS individuals usually have more exacerbated symptoms. But when we try to compare and differentiate between patients that do have and experience symptoms and ME/CFS individuals, we see that there's a very wide overlap between them. And given that ME/CFS is symptom-based, that the diagnosis of ME/CFS is symptom-based, this might lead to this, well, got me thinking that there might be an impact of in research when we actually diagnose individuals that are not ME/CFS as being ME/CFS and include them into the cohorts for the studies. So we now enter into the hypothetical and more theoretical ideas. So if we think about a typical case control association study, we usually want to investigate the association between a candidate causal risk factor and ME/CFS. So to do that, we identify and diagnosed a group of ME/CFS individuals and find a sample of healthy controls matched for any potential confounding factors. So we screen these two populations for the presence or absence of a risk factor, and if it shows, sorry, no, yeah, so we screen the two populations and we compare the results for this presence or absence of a risk factor. And if we manage to reject the hypothesis that these two populations are the same, we get to infer on the link between a causal risk factor and the disease. But under the hypothesis of misdiagnosis, we assume that this diagnosed ME/CFS population is actually a mix between true ME/CFS individuals and apparent ME/CFS patients that essentially acts as a diluting factor towards us finding this true association between a risk factor and the disease. And the more apparent cases we have, the less power we have to identify this true association and link any candidate genetic biomarker or exposure to any virus and the disease. So we did a simulation study where we sampled ME/CFS individuals and healthy controls and assumed that these false positives or these apparent ME/CFS individuals were in fact shared this risk factor probability as the healthy controls. So the more false positive individuals we had, essentially, the more diluted the true results would be. And so we, just to be very quickly, we played around with multiple parameters, such as the sample size of the studies, how strong the association between finding a risk factor and diagnosing the disease was, and how prevalent it was amongst the populations. And our result is show that if we have an ideal study scenario where we have more than 1,000 individuals per cohort, and we have a very strong association that is present in, it's an easy to identify. So the probability of rejecting, so how consistent a study is at finding this association doesn't really matter on how misdiagnosed individuals are. So if we have a misdiagnosis of 0, we are comparing only ME/CFS individuals versus healthy controls. And if we go all the other sides to the other side of the spectrum, we are comparing only apparent ME/CFS individuals, so false positives, versus healthy controls. And under a perfect and ideal, well-funded scenario, we could have even more than 80% of the population being misdiagnosed, and we could still find this to be statistically significant. Sorry, I'm just going to try and change this. Yeah, I'm just about to. So sorry. Maybe it will work this way. Okay, so, but this is not real-life ME/CFS research. So usually, for instance, we work with smaller sample sizes and associations that we try to go for and research are not that strong. So it's not a monogenic disease. It's something that it's much more nuanced. So we need to decrease the effectiveness of, or the strength of the association between finding a risk factor and actually being diagnosed with ME/CFS. And this further reduces our ability to detect the association. And since we are talking about a disease that only affects up to 1% of the population, and we have to look at specific markers for either autoimmunity or infection, which tend to be reduced in within the populations. So under the assumption of misdiagnosis, we can see that even in a perfect scenario where we are comparing healthy individuals against only true ME/CFS individuals, and we do replicate multiple studies, we would still get about only 50% of the studies. We will manage to find this true association, while the other 50% would not find this association. And you can see how conflicting this eventually becomes. And just my take-home message is that under this assumption that there's a misdiagnosis and inclusion of false positives or individuals that are being diagnosed as ME/CFS but are not in fact true ME/CFS, ME/CFS research has a suboptimal power, and we need to compensate for this by increasing sample sizes, implementing standardized case definitions or more restrictive ones, as Luis mentioned, and we should focus on more specific pathological mechanisms for the disease. And the silver lining here is that if we account for this, we can in fact significantly reduce misdiagnosis, but it takes a collective effort. And this is why these conferences are so important, because we get to share as much information, learn as much as possible, and eventually share data amongst ourselves to do multicentric research. And thank you.
Thank you, João. We will take the question in the end. So it's my pleasure to introduce Joanna Squires, which is an exercise physiologist who will speak about investigating ME/CFS and long COVID through ICPET. Okay, go ahead.
Nice. All right. Good afternoon, everyone. My name is Johanna Squires. I work at Mass General Brigham in Boston. And today I'm going to talk about our invasive CPET testing and autonomic function testing in ME/CFS and long COVID. Very quickly about me, my PI is Dr. David Sistrom, but I also work with Dr. Aaron Waxman, who's in the crowd, and my background is biomedical science and exercise physiology. To the patients out there, I promise I'm not going to tell you you have to exercise. I try and say that with every presentation. To start off, due just to time restraints, I'm not going to go into the grittiness of the ICPET. Dr. Sistrom, Dr. Waxman, Dr. Oliveira are going to talk tomorrow, and for the non-invasive one, Dr. Keller and Dr. Wink are speaking tomorrow. Just a very brief overview. A lot of you might be familiar with just the normal non-invasive CPET. What we do at the Brigham is we put catheters in. So we put one through your pulmonary artery and one in your wrist to get your arterial line. And what that permits us is not just oxygen uptake or oxygen utilization, but it also lets us look at pressures within your heart. It also lets us do arterial and venous oxygen content differences. So it's a pretty exciting test that we do quite frequently. So how can we use that in ME/CFS and long COVID? This is currently being written up as it is, but we wanted to compare the three, and we have a pretty good size. So we have about 1,600 people that have had an invasive CPET between 2019 and 2025. And then out of them, about 477 met ME/CFS IOM criteria. So my team doesn't just look at ICD codes. We go through all 477 people and do a complete chart review. For long COVID, we are doing IOM criteria as well, but following a confirmed COVID-19 infection. And for the controls, I take out every comorbidity known with ME/CFS and long COVID, so small fiber neuropathy, mast cell activation, Ehlers-Danlos syndrome, also taking out pulmonary hypertension, heart failure, the many other reasons why people get referred for invasive CPETs to get a symptomatic control group. And what we see here is that between ME/CFS and long COVID, there is no significant difference, but compared to those controls, it is significantly different for many of the major variables. And in particular, I want to draw your attention to peak right atrial pressure. That's where I'm going to be taking this presentation today. And peak right atrial pressure has been previously written about by Dr. Will Ordem, who also was working with us at the Brigham in 2015. And what he found was there's this phenomenon of preload failure or low filling pressures in the right atrium, less than 6.5 millimeters of mercury. And then in 2021, Dr. Philip Joseph took this and applied it to ME/CFS and controls and saw that there was almost 100% of preload failure in ME/CFS. Now, when preload failure pops up on the test, Dr. Sistrom, this is a screenshot of one of his interpretations, will point out that the root cause appears to be preload insufficiency, as the right atrial pressures are essentially unmeasurable throughout upright cycling exercise. It eventually goes to long COVID-related dysautonomia. So that's where I'm going to take this, and that obviously with dysautonomia, be great to get a positive skin biopsy to adjudicate. So autonomic function testing is not just skin biopsies. It can be made up of the following. It can be a combination of the following. So you have electrochemical skin conductance, or ESC, quantitative pseudomotor axon reflex test, or QSART, both of which are looking at sweat production. You have tilt table testing. So I know patients will be very familiar with POTS and how It's a tilt table test or the NASA lean test of being diagnostic for that. And then you got skin biopsy. So the very common one being an epidermal skin punch biopsy, but there's also sweat gland biopsies. So what I wanted to do is kind of gather all of that, potentially also with epidermal, we know it's patchy. With sweat glands, we know they're deeper. So I wanted to take all of that and just kind of see where that leaves us. So this has been previously looked at by a group in Spain in 2023. And so I wanted to take our number. So that previous group of 477 ME/CFS patients, of that 477, 420 of them have also had autonomic function testing, which is not a bad group of them. And with long COVID, of the 93, it's 59. So I wanted to focus in on them. Now, before we move on to the small fiber neuropathy aspect of this and dysautonomia, I do want to just point out with that tilt table test, it did catch 31% in ME/CFS, which is sometimes higher than what other groups find. So we'll see going into that. But I wanted to focus on the small fiber, and there's a reason, and that's going into my next one. So with these colors, the darker pink is negative. So for small fiber neuropathy and ME/CFS, it's 36% negative. But if you look at the two blue, 24% is probable and 40% is definite. Now, what do I mean by probable or definite? Probable, if you're talking to a neurologist, would be the ESC or the QSART. If you're talking to a clinician, it's that neurite density. So to be true small fiber neuropathy, that neurite density has to be less than the 5th percentile. But what if a patient comes in with an 8th percentile? What if they come in with an 11th? A lot of the time, clinicians will just group that together and they will move forward with treating them for small fiber neuropathy. And so I kind of broke out to the little side of the pink being epidermal skin biopsy being positive. So that's less than the 5th percentile. And the light blue is sweat glands, less than the 5th percentile. But if you wanted to approach it like a clinician, you would add the 24% and 40% for ME/CFS, and for long COVID, 22%, 51%. What that's getting here is 64% probable or positive for small fiber neuropathy and ME/CFS, and 73% in long COVID. Now, I wanted to see how this would relate to our ICPET. I'm always trying to bring it back to that. So what I did is I took negative, probable, definite by epidermal skin biopsy, and then definite by sweat gland biopsy to see if there's any significant correlations with our ICPET. Plot twist, there weren't at the current moment. We do have the constant thought, does structure equal function in this case? And so I'm going to focus more in here. I think there's a lot with just the phenotypes in the disease. But the last part that I want to get to before the end is the tilt table test. And I wanted to specifically focus on Dr. Peter Novak's tilt table test, just so that it would be consistent amongst all of them. So of the 420 ME/CFS with AFT, we got 157 and then 31 long COVIDs. This is where those are the ICPET and the tilt table test are two very, very common tests for ME/CFS patients in Boston. And I wanted to see if there's any correlations between the two tests. And what I found most interestingly, if you can think back to when I did ME/CFS versus long COVID versus controls, is that there was a greater change in heart rate from supine to 70 degrees upright to worse peak right atrial pressure, meaning dysautonomia caught on the tilt table test also correlated with the dysautonomia caught on our invasive CPET. And then finally, in conclusion, just to summarize, long COVID and ME/CFS perform similarly on ICPET, but they're significantly different than symptomatic controls. Dysautonomia doesn't only have to be captured by AFT, but can also be caught during our invasive CPET. And small fiber neuropathy is common in ME/CFS and long COVID, but its role in systemic vascular regulation and exercise intolerance warrants some further investigation, maybe find some biomarkers so that we can do targeted treatments. Thank you.
Very impressive. Thanks so much, Joanna. Now it's time to the next speaker, which is Massimo Nunes, coming from Stellenbosch in South Africa. He's going to make a speech on dysregulated coagulation system in ME/CFS. Thank you.
So, hello everyone. Just quickly, on behalf of the South African cohort, the small group that we have, it's an honor to be here, and thanks for the invitation. And I've been doing a lot of work this year on long COVID, diabetes, but I think it's really important to give attention to our previous MECFS work. And just to backtrack a couple years, Prof. Pretorius in 2020, 2021, she discovered these endogenous preformed fibrin aggregates that we call microclots in the blood of long COVID patients. For the last few years, we've done some extensive elaboration on these aggregates, if you will, and learned that they're a lot more complex. There's various phenotypes, but I'm going to leave that for Prof. Pretorius' talk tomorrow and not talk too much about them. So, 2021, patients actually prompted us to do similar investigations that we were doing on long COVID on MECFS. And we listened. We looked at the data. We saw that there's actually not many coagulation-focused studies in MECFS. And we know that it's not a primary pathology, but certainly dysregulation in the system might be relevant for symptoms, might be relevant for some kind of pathology. So it kind of warranted a modern investigation into coagulation into MECFS. So we recruited a control cohort, an MECFS cohort from the MECFS Foundation of South Africa. And just to take you through one of the techniques that might not be commonly known, it's thromboelastography. It's actually a bedside technique used in the hospital, in the clinic. It's to measure coagulation. And instead of measuring just certain factors within the cascade, this measures coagulation as a whole from start to finish. So it's quite comprehensive. And you don't have to know all the parameters, but there's some parameters related to kinetics and some related to clot size and clot strength. I'll take you through it. So we wanted to assess the whole blood against a clinical standard range that they use in the clinic. And for clotting kinetics, for 3 out of 5 parameters, more than 50% of the population fell out of standard range, all towards the hypercoagulable prothrombotic terminal. And again, the clot size and clot strength related to the maximum amplitude, that was also more than 50% of the population. So really, this is clinically significant data as it is already, and would likely prompt clinical response in the clinic, whether it's administration of, in this case, anticoagulant drugs, or if it was the other direction, obviously prothrombotic drugs, but that's not the case here. We assessed the platelet poor plasma against a control group, and we found significance for several parameters, but only really a real significance for 2 of the parameters, alpha angle and maximum rate to thrombus generation. And just a quick distinction between analyzing whole blood and platelet poor plasma is obviously the contribution of cellular fractions, platelets, red blood cells, and so on. We also assess platelets by microscopy. We use 2 markers particularly that can bind platelet activation markers, glycoprotein 2b3a and p-selectin, not that that's too important. And the image on the right, don't be deceived, we actually did not find too much platelet aggregation in the MECFS cohort. This is unlike what we see in long COVID, but we certainly did find activation, and we certainly know from previous research in the last 5 years, platelet dysregulation is certainly a component of subtypes or subgroups within MECFS cohorts. We also assess microclots, and we use a marker called thioflavin T, THT, that can bind these things and visualize them. Qualitatively, looking at these images, we can see that they are larger, we can see that they are numerous, but admittedly, this is not a quantitative technique, this is qualitative. And really what we wanted to do was get a quantitative grip on microclots. So we developed a cell-free method to image and analyze these things and quantify them. And in this particular assessment, we included a long COVID cohort, just for reference. And as expected, the long COVID cohort had a greater mean. The MECFS still had a very significant median compared to the controls. We also broke this up into various size ranges, because just getting an average of microclots that are 1 micron squared all the way to 600 is not necessarily statistically interpretable or correct. And we can still see that the burden and the count was higher in each size range. Lastly, we did a mass spec analysis, a proteomics analysis, and we found some proteins related to the coagulation system that can really substantiate or give mechanistic insight into the previous findings with thromboelastography and microscopy. Platelet factor 4, for instance, on the right, that can explain or just corroborate the platelet dysregulation and activation that we saw. But protein S and thrombospondin coming from the endothelium, protein S is an endogenous anticoagulant. the reduction in this protein can certainly explain the increased clot kinetics, the increased clot load, and thrombospondin 2 also activates platelets. So we really got a nice network here explaining the previous findings. Also, we know that blood flow is significantly dysregulated in ME/CFS and long COVID too. Cerebral blood flow, there's a lot of perfusion deficits, and what we are interested is thrombospondin's perhaps mechanistic role in this regard, and we've been focusing in on that quite a lot, and hopefully we'll have some results in that early next year. What is important here is that we did not necessarily find a dysregulation in clotting factors per se. And as we know, this is not a primary coagulation disease, but likely just a byproduct of a dysregulated endothelium as shown here. We also found a downregulation of complement proteins, various markers related to 3 of the complement pathways, and some other proteins too, protein S100, pro-inflammatory protein. Hemopexin is a protein that scavenges heme from life's red blood cells. And again, a lot of research recently is kind of showing that there's a lot of red blood cell dysfunction too and lysis. And ultimately, we showed some overlap between what we see in coagulation in long COVID and ME/CFS. But again, it's likely a result of this endothelial dysfunction. And if we look at research in the last 5 years and even beyond that, we know that endothelial dysfunction is a major component of post-viral disease, and it's been shown more and more, and mechanistically, we are starting to dive deeper into that. And I guess this is, I would consider an exciting field and something that I'm very interested in. And we think that the endothelium might be intimately involved with a lot of the symptoms and mechanisms too. And whether it's a primary defect in the endothelium or a loss of autonomic control or some neurovascular dysregulation, we still want to look at the vasculature itself and its ability to give rise to these symptoms and be central. And perhaps a lot of the tissue findings that we find in these diseases too could be secondary to some vascular disturbances or insufficiencies. I also do have a poster related to, I would say, more so coagulation, but using long COVID as a model. So please come see that too. Thank you.
Impressive. Thank you so much. Last but not least, I would like to present the next speaker, which is Gustavo Couto. He's a recent graduated medical doctor from Porto Medical School. He will speak about SARS-CoV-2 long-term impact on myocardial reverse remodeling. Thank you.
Hi, everyone. First of all, I would like to greet each one of you here today, and I would like also to express my sincere gratitude to Professor João Carlos Wink for giving me this opportunity to be here speaking about such an important end-year project of mine, which is the Long COVID project. This project has been conducted since 2022 in the Medical Research Center of the Faculty of Medicine of University of Porto by the Myalgic group, which is led by Professor Inês Falcão Pires. I initially joined Myalgic about 2 years ago in order for me to develop my master thesis in medicine. And so today I'm here to talk about it. Since the beginning of the pandemic, the Myalgic group rapidly identified not only a huge gap in terms of clinical and scientific knowledge, but most of all, they identified an opportunity for them to further explore the scope of their investigation. They are mainly concerned about the cardiovascular physiology and pathophysiology in multiple conditions. It became quite clear since an early stage that COVID-19 was associated with a significant acute impact on the cardiovascular system, with multiple forms of cardiac involvement being described in the literature. Beyond this short-term and acute impact, there's now growing evidence that suggests a persistent cardiac dysfunction among survivors of SARS-CoV-2 infection, namely through an increased long-term risk for cardiovascular disease, and also through imagological and analytical abnormalities among these patients. We all know what is the definition of long COVID, so I'll skip this slide. What you may not know is that cardiovascular manifestations represent the third most frequent category of
Oh, sorry. Será que não está ninguém daqui que possa lhe dar uma ajuda? Isto é outro. Não. Ficou aqui o primeiro slide. Espera aí. Ok, já está.
Sorry about that. As I was saying, what you may not know is that cardiovascular manifestations represent the third most frequent category of long COVID symptoms, surpassed only in frequency by the neurologic and neuropsychiatric symptoms and by the respiratory symptoms. Considering this long-term impact of the COVID-19 on the cardiovascular system, a big focus of long COVID was to investigate the potential impact of SARS-CoV-2 infection on the surgical outcomes of patients with aortic valve stenosis. Likewise, we conducted a multicentric observational study, including patients with a diagnosis of moderate to severe aortic stenosis, according to the European Society of Cardiology guidelines, that were referred for aortic valve replacement surgery at one of two different centers, at Unidade Local de Saúde São João or at Hospital de Santa Cruz, which currently is part of the Unidade Local de Saúde de Lisboa Ocidental. You may be wondering why we restricted our population to the patients that had a pre-established diagnosis of aortic valve disease. And the reason why we did this is because one of the main goals of our study was to establish in detail the myocardial histology, as well as the molecular processes that may be underlying this long-term cardiovascular involvement in survivors of SARS-CoV-2 infection. And so it was really mandatory for us to have the potential for obtaining myocardial biopsy specimens through myocardial surgery. At Unidade Local de Saúde São João, patients were recruited on the day of their respective hospital admission, and they were given a detailed questionnaire which allowed their allocation into one of three different groups: the group of patients with no history of previous SARS-CoV-2 infection, the group of patients with a previous history of SARS-CoV-2 infection that was followed by complete symptomatic resolution, and finally, the group of patients that fulfilled the criteria for long COVID. At the time of their hospital recruitment, each patient had already undergone an echocardiogram, and a new echocardiogram was performed 3 to 6 months after surgery. In terms of the patients recruited at Hospital de Santa Cruz, the protocol was quite similar. The patients were again given a questionnaire that allowed their allocation into one of the three pre-specified groups. And then we rearranged all the data into a new database and performed the statistical analysis. We first investigated for differences between the three groups, the no COVID, acute COVID, and long COVID groups. And additionally, for the echocardiographic variables, we also tested for differences among between the two time points, before surgery and 3 to 6 months after that. The results that I am presenting here today concern a total of 96 patients, of which 13 had a history of SARS-CoV-2 infection that was followed by complete resolution, and 7 of which had an established diagnosis of long COVID. Albeit these numbers are admittedly small, I would like you to view these results as a preliminary insight, almost as a first look into what this study may reveal in the near future. As you may know, aortic stenosis is a prevalent condition that exposes the left heart to an increased afterload. And as a result of this valvular dysfunction, the heart undergoes a maladaptive process of cardiac remodeling that is essentially characterized by a concentric hypertrophy of the left ventricle. It is expected that after AVR, a process of reverse remodeling occurs, in which the heart regains its initial form. This is called a process of cardiac reverse remodeling. Our results are consistent in identifying a benefit of the surgery in terms of the transvalvular aortic gradients. And overall, our results also show a significant reduction in terms of left ventricular mass, as well as relative wall thickness, which are considered two hallmarks of left ventricular hypertrophy. However, although this reduction retains its statistical significance when the group of patients with no history of infection is considered separately, the reduction is no longer significant in the group of patients with a previous history of SARS-CoV-2 infection, whether followed by complete resolution or evolving into overt long COVID. Albeit this population was really small, I think we can all agree that this study highlights the need to establish objective criteria to accurately identify patients that may be suffering from chronically sustained long-term cardiovascular compromise through an history of SARS-CoV-2 infection. The fact is that we found out that a lot of patients that had a previous history of SARS-CoV-2 infection may be less prone to responding to the reverse remodeling of the heart that is expected after surgery. And so I think this really is a glimpse of what we might get in the near future about these studies. And I would like to thank everyone who has contributed to this study, more directly or indirectly. And I would like to thank everyone for your attention.
Thank you so much, Gustavo. I'm sure that Dr. Systrom's group would love to have ICPAT on these patients before surgery, right? But I think we have time for a couple of questions. I know that we are like 10 minutes delay, and our fantastic host, John, will lead the next panel. So I'm sure that she will say that we can have some time for questions. Yeah? Is there any question? Oh yeah, a couple of questions. Go ahead. Introduce yourselves.
Rob Busti from Amsterdam. Gustavo, very nice work on the heart samples. Are you planning to do any other measurements on these heart samples?
Sorry, I didn't.
So you collected samples, right, from the aortic?
Oh yes, we collected samples from the patients that were recruited at Hospital de São João. Of course, we did not do it in all the patients because there were concerns about the surgical feasibility of this collection. And so the collection of the samples were only performed when there was like a clinical possibility to do so. The patients recruited at Hospital de Santa Cruz, those ones did not give us material, biopsy material, because they were included in a previous study, and so there was more like a retrospective study in nature. But
so your long because the most interesting samples, of course, are the long COVID samples.
Yes.
So I spotted on your slide that you only had 7 people included in your slide. Were you able to get any samples from those people?
Sorry, I did not.
There were only 7 people. On the
7 people, yes.
But did you get any like samples, like tissue samples from those people?
Yes, we did. We have some preliminary results. Cool. The one that stood out the most for us was really the cardiac fibrosis. We had some insights about also the pericardium and the pericardial fluid, but the cytokine profile of the fluid was significantly different between patients with long COVID and patients with just a history of fully resolved infection. But I have to say that the results of the pericardial fluid were really difficult for us to interpret in terms of our theoretical knowledge. But the ones that really stood out were the histology of the myocardium, which revealed a significantly amount of fibrosis, and we were not expecting such a huge finding.
Thank you all very much for the beautiful presentations. I also have a follow-up for Gustavo. Really super interesting work with the cardiac tissue. I guess this is maybe two questions. I might have misheard, but you saw a decrease in ventricular mass with the long COVID patients, but I think you followed that up by saying that you also saw consistencies with left ventricular hypertrophy. Can you maybe elaborate or clarify that point? Because in my head, the hypertrophy should then go with an increase in mass.
So when we have an aortic stenosis, the heart usually responds by increasing the left ventricular mass, that is the ventricular hypertrophy. But when the patients are surgically interventioned, the valvular function is back to its original form. So the afterload is relieved. And what we expect after the surgery is that the heart reverses the process of the cardiac remodeling. So the hypertrophy is no longer detected, or at least it is partially normalized back to its original form. What we found out was that in the group of patients with no history of infection, there was a significant reduction in the left ventricular mass, which was what we expected to occur. But in the other two groups, which were the ones who had a previous history of SARS-CoV-2 infection, whether it was followed by a complete symptomatic resolution or by overt long COVID, there was no significant reduction. So the patients retained higher levels of ventricular hypertrophy, even though they had the same alleviation in the afterload.
Okay, awesome, that's clear. And could I do one follow-up? Was this also accompanied by a decrease in distensibility of the cardiac tissue in any way in either the ventricles or the atria?
Well, we investigated different types of echocardiographic parameters. The ones that I brought here today were the ones about the morphological parameters of the myocardium, but we also investigated the diastolic function parameters, E and E prime, and its ratio. And we also performed analysis in terms of left ventricular ejection fraction, in terms of the systolic function. But the results were not quite understandable. There were no significant reductions. And the reason I think this happened because we are dealing here with aortic stenosis patients, and the only thing that is actually really established to occur after the surgery is the reversion of the left ventricular hypertrophy. Even in controls, we do not seem to observe every time an increase or a decrease in left ventricular ejection fraction, as you would predict. I think it is a little, your intuition says that the ejection fraction is going to be improved in normal patients, but this is actually sometimes not the case, even among controls. So we did not find any statistical significant results. That's why I didn't bring them today.
Last question. Yeah, great panel. Thank you all for your presentations. Actually, my question is not to João, because he was my former PhD student. It's actually to Massimo. If I understood correctly, you said the coagulation system is affected, but it was supposed to be like downstream effect, not like. Did you try to correlate that with disease duration if you had that information in your patients?
Yes, we definitely did. And if there was a good correlation, I certainly would have presented it. We did not get many correlations. I would say the highest we got is a R-squared of 0.7 for some of the TG parameters and few of the symptoms. And if I remember correctly, it's neurological. So certainly we would require a more in-depth study, better design study perhaps, and hopefully we'll see a correlation there. But again, the coagulation system is something that's very easily influenced by pathology in various other systems. And we know the endothelium is so tightly regulated it tightly regulates coagulation. So I think minor dysfunctions in there would show dysfunction in the coagulation system. perhaps if we redesign the study and focus more on endothelial markers and endothelial dysfunction and correlated that to symptoms, I would suspect we would have got a much better correlation.
I was just wondering if it actually you could have done like some kind of like a regression analysis where actually include all these type of features, and then you try to explain the effect of age, effect of disease duration, even on severity.
Yes.
That will give you a more broad picture of your finding. Yes. Thank you very much. It was very interesting.
Thank you.
Okay, thank you all. Very good.
One question for Joanna, please. Double. So, Joanna, you are involved in Young Emerge, and I believe some of you. Are you here? Okay, so the questions for Joanna. Joanna, I know you are an active participant in Young Emerge. I don't know, Massimo, João, and Gustavo, you need to join. Could you tell us a little bit about this initiative? And also, congratulations. This is not a secret. This is my favorite panel because it is, because really you represent emerging areas and new energy and the future of the work. So thank you. So you could do a little pitch, please.
Yeah, of course. So some of you might be familiar with Emerge, which is the European Coalition for ME Researchers. The youngins decided to make their own group, so Young Emerge. It's not just limited to Europeans. I somehow snuck in. But what it is we meet, discuss journals. We even have our own kind of mini symposiums before big conferences such as this. We encourage all levels of research. So I don't yet have my PhD, but I can actively participate in the different activities. I know they're going to Vienna this month. Anouk, are they? Yeah, okay. And doing, basically, they fund some scholarships of exchanging to go to Vienna or for the Austrian students to go elsewhere. So it's almost its own fundraising. It's a way to network. It's a great way just to connect so that the young researchers can hope to fill the shoes of our PIs.
Can I ask one small question for Massimo and Joanna? When we don't still want to invasive CPAP in Portugal, I'm correct? When you're doing it in the States, do you also do blood work, and does the blood work include coagulation samples, and would those coagulation samples help Massimo in expanding his research?
I actually think that both of our PIs were talking about that last night. So yes, we do minute by minute blood sampling. Sometimes it's every 2 minutes, but we definitely catch resting, peak, and then an hour post. If they consent to just keeping the lines in for that time. But we are working on a material transfer agreement right now because we're sitting on a whole biobank of samples. So it'd be nice to send them over.
So no, send samples to you as well because that will expand your
Okay, so okay, thank you so much. Fantastic job you've done. Your early career will be fantastic for the future, I'm sure, for ME research. So thank you again for your talks. And let's hand over to Professor Vaz Carneiro.
Thank you, guys.
Thank you.
Thank you. Buona. Tá bom. Sim. Tá, vamos lá depois. Okay. We are now heading to the patient advocacy panel. And I should call now Joan Sarah Hoffman. She is well known. She is founding co-director of the Inter-American Coalition for Violence Prevention, which promotes the public health approach and coordination between a whole bunch of national and international institutes. She was elected as the next generation fellow by the Rockefeller Foundation for her work in public hospitals, level 1 trauma, and public health departments and with victims of violence. She retired from the World Bank due to ME CFS. Joan, the floor is yours.
Who is
Sure. Do you have everything you need? Okay. Thank you.
Good afternoon, everyone. My name is Katarina. I'm a carer for my daughter who's ME/CFS for the last 4 or 5 years. Previous to that, she's had other comorbidities, but COVID brought ME/CFS. And I would then like to present Sean Leary. Did I say it correctly? Is it Sean Leary? Is it correctly? Did I say correctly? Sean Leary. Is she here? She's joining us online. Oh, she's joining online. Okay, sorry. Sean Leary these are notes from Joan, professional expertise in different roles in ME's advocacy and research, and is also a member of Active ME. May I ask you then to introduce yourself further, and thank you for joining us. Is Sean there?
Yes. Talking to you today about patient and public involvement in research, or PPI. This refers to the active involvement of patients and the public in shaping research, ensuring it reflects real-world experience and that it meets real-world needs. I'm a member of the DecodeME Genetics Study Patient and Public Involvement Steering Group, and I coordinate PPI for a new project called PRIME, a research infrastructure building project for ME. I also live with ME myself. That dual perspective, both as someone with ME and as someone working professionally in the charity and research sectors, has shaped how I approach involvement. And it's shown me just how powerful it can be when done well. So I want to share how DecodeME built a gold standard model for patient and public involvement, PPI, and how we're building on that through PRIME. For those who don't know, DecodeME is the world's largest study of ME/CFS. We've collected over 18,000 DNA samples and already identified 8 genetic signals that influence the likelihood of developing the illness. This is a huge step forward for ME research and gives us so many clues on what to investigate next. It has also been incredibly validating for people with ME, many of whom have battled stigma and denial of their experiences since getting ill. But DecodeME isn't just a scientific and social achievement. It's a model for how we embed lived experience into research in a way that improves impact and scientific quality. DecodeME has been a huge collaboration. We have researchers, teams that deliver specific aspects of the study, communications experts, and people with ME all working side by side. Our PPI steering group is embedded in the project's governance. Everything from press releases to the ethics application to the risk register was reviewed by the steering group, meaning our experiential knowledge formed a key lens through which every deliverable was passed. Members from this group sat on each of the other teams and were conduits for information and decision-making. We weren't just consulted, we were part of the decision-making. And when capacity fluctuated, as it often does with ME, we adapted. We brought in additional contributors or had PPI steering group members join additional teams to ensure that continuity. That flexibility there was key. It meant that we could maintain momentum without compromising accessibility or inclusion. And I know for me, being able to pass the baton on to trusted PPI colleagues during periods of worse health was incredibly reassuring. So what does accessible involvement actually look like? Most of our meetings happened online. Meeting times, durations, and formats were all shaped around the needs of each group's PPI members. Some team members met for just 30 minutes at a time, others for an hour or more. Where people struggled with light sensitivity, staff made presentations with dark backgrounds, and they were always open to different methods of communication, be that emails, Teams, phone calls, whatever worked for the individual. We shared agendas and documents well in advance to help PPI members pace their energy and involvement, and we co-created timelines. I'm not alone in having attended meetings from my bed on crushy days, and I was never made to feel my involvement was lesser because of that. Plus, we tried to ensure involvement didn't need to be all or nothing. This wasn't always easy for the individual. Some of us pushed past our limits because we were so invested in the project, but the principle that people could step back and rejoin as their health allowed was always upheld. One of our biggest contributions was developing the participant information documents and the DecodeME questionnaire. We tested all these documents with small groups of people with ME, made changes based on their feedback, and saw a 20% increase in correctly completed postal questionnaires because of this. That's a direct impact on data quality driven by PPI. We also helped shape how DecodeME supported its participants. PPI contributors wrote sensitive, thoughtful responses to common queries from participants. And when more complex questions came up, we worked with staff to craft responses that reflected the experience of ME. This made the study more responsive, more human, and built impressive levels of trust with the community, enabling us to build a big enough cohort of participants to power our analyses and find the genetic signals that we have. And our involvement didn't just stop at design. We were active in delivery too. PPI members helped create a video guide for returning DNA spit kits and edited our outward communications for accessibility. We also co-hosted webinars with researchers that reached tens of thousands of people. This wasn't just about inclusion for the sake of it. It was about impact, and it worked. This is what true involvement looks like. Not tokenism, not consultation after the fact. Our principal investigator, Chris, devolved decision-making. Together, we embedded PPI in governments. We budgeted for contributor fees, and we created space for people with ME to shape the research from the inside. Personally, I've gained so much from co-producing DecodeME. It's helped me grow, supported my career, and given me friendships and connections that I truly cherish. And it was meaningful for staff too. One team member told us, "This is the most fulfilling role I've ever had." DecodeME is still analysing data, and PPI members will be co-authors on future publications, including one on PPI itself. But we're also building on this model through PRIME, a new UK Medical Research Council funded project to strengthen ME research infrastructure. PRIME has three main aims. The first is creating at least 15 new research collaborations to coordinate and engage researchers over the next 4 years. The second aim is to build 2 international consortia, one focused on genetics and the other on molecular biomarkers. And thirdly, I am hugely excited to now be working for PRIME to create the world's first large-scale pool of PPI contributors for ME research. At least 100 people with experience of ME, either as patients or carers, trained and ready to co-produce research. And it means that future ME research can be shaped from inception by people who truly understand what it's like to live with this illness. This is all about making meaningful involvement easier, faster, and more effective for researchers, while ensuring that research stays grounded in real-world experience. As many of you already know, the ME community is full of brilliant minds. Faced with a lack of care and treatments, many of us have extensively read the research literature around ME, trying mostly in vain to find something that could help us. Some of us are trained scientists, others just geeky lay people. But whatever our background, our experience of ME gives us a vital role to play in research. And when we involve people meaningfully, we don't just improve the research, we accelerate the search for treatments and one day a cure. In time, PRIME will be actively recruiting researchers and industry partners to join our network and members of the public to join our PPI pool. So keep your eyes peeled. There will be new opportunities to collaborate just around the corner. Thank you.
Can I call Letitia then? Right, then our next presentation is from Letitia Soares. She's a biologist on the Patient-Led Research Collaborative. And she's a trained biologist with background in infectious disease, ecology, evolution, epidemiology, and she co-leads Patient-Led Research Collaborative research and coordinates with external partners in academia, industry, and government agencies. She also has long COVID since 2020.
So I'm one of the co-leads of the Patient-Led Research Collaborative, and I will be talking about benefits, challenges, and recommendations of incorporating patient representatives in research. So the Patient-Led Research Collaborative, it's an interdisciplinary group of people with long COVID and associated conditions with expertise in the sciences, technology, policy, and media. We are about 50 people, both patient researchers and advocates, and we are located across 5 continents. And since we began doing this work in April 2020, we have authored or co-authored more than 40 papers in the field of long COVID. Our mission is to improve the breadth, depth, and speed of global research into long COVID and associated conditions, and to advocate for policies that improve the quality of life for long COVID patients worldwide. So what is the role of a patient researcher? Patient researchers combine domain and lived experience expertise. They bridge knowledge gaps. They ensure the relevance of research design, address equity issues in research, and contextualize and translate research findings. There are several key benefits of embedding patient participation and patient engagement in research. The main one is study design and questions that reflect disease heterogeneity and lived experience. And this is very important in the context of infection-associated chronic conditions in general. And when patients are embedded meaningfully in the research process, we do see a higher impact and efficiency of research because research priorities match patient needs. Other key benefits include lower odds of iatrogenic harm in clinical studies. So considerations to prevent PEM and CAS, for example, are often overlooked, and yet they are essential. So patients are not harmed when they participate in research studies, and that's something that we often point out, like how to improve and how to prevent PEM and other potentially harmful events that can happen in participation. Participation enables accurate representation of the disease experience. For example, inclusion of symptoms that drastically affect patients' quality of life. For instance, PEM, which is to this date is not included or considered in several long COVID studies, like including clinical trials. And another example are symptoms associated with the menstrual cycle. And the patient engagement can enable improvements in inclusion and diversity. For example, our work in the project in collaboration with the Osvaldo Cruz Foundation in Rio, we helped adapt the wording of the symptom survey that reflected both patient experience and enable participation of people with low socioeconomic backgrounds in this study. But there are several challenges, and based on what we have learned so far, we know that patient researchers, when you embed people with expertise and lived experience expertise into the research process, there is this challenging of assumptions of who should produce knowledge, and we are constantly in attrition with hierarchies of power dynamics. So you can expect a disagreement, which is often healthy. And one recommendation to make this process smooth is to plan for shared decision-making, to really have a model of governance that acknowledges that, and a mediator in the team to help with conflict resolution and consensus can really help. Another challenge is a lack of or insufficient planning of patient engagement. So patients often are brought in after the project begun, constraints the input that patients can offer. So for example, if you bring in patients after you submit your IRB, it's very likely that you're gonna have to amend your IRB because of suggestions that patient researchers make. And one recommendation to make this process more efficient is to co-create and co-develop projects with patients and have an engagement plan. And we developed a tool to guide and evaluate that, which are the patient-led research scorecards, and we encourage researchers to use that. Another challenge is fair compensation plan for patient researchers. So please do consider this as labor, because it is, and researchers need to budget accordingly for this collaboration with patients, and also be upfront with patients about what budget they have to support the type of work that they are expecting. Another challenge is accessibility of participation, which is often, it's a problem in academia, and it's often an afterthought that hinders patient participation. And biggest recommendation here is to put accessibility at the forefront. Consider access needs specific of the patient population and flexibility in the modes of participation. For instance, some patients don't tolerate long meetings or even video calls, so make sure that there are opportunities for these patients to provide input into the project. Finally, one challenge are triggers, trauma, and how this work affects the mental health of the patient researchers. Because often we are facing triggering situations and interactions, and we have to advocate against practices that have harmed the patient community, including ourselves. And one recommendation is just, this should be really the bare minimum, is to familiarize yourself with the history of infection-associated chronic conditions, especially in CFS, and do not repeat the same mistakes. And another thing that you can provide to patients is have multiple patients in the team and have a support system. So for example, in our group, we have a dedicated Select channel for specific support in research participation, where we can share the challenges that we have been facing with this type of work. I would like to thank you so much for listening, and I would take this opportunity to invite everyone to join our registry. And if you have any questions or comments, please feel free to reach out. Thank you so much.
Good afternoon. Thank you for the presentations. And hi, Sean as well. How are you today? Can't hear you. Letitia, also we not hearing you.
We can hear each other.
Yeah?
Yes.
We can hear you now.
I think they cannot hear us there.
Okay. We have a question for Sean. How do we sign up for Prime PPI? And for those that don't know, what is PPI? For people that are watching us for the first time.
Okay, can you hear me now?
Yes.
Fabulous. So yeah, it's a joy to be here. Thank you so much. For Prime PPI, we don't have a way of signing up yet. I'll just be upfront about that. We are in the very, first month of this project, and so that's something that we are going to talk through. We've got a few PPI members who are already involved, and I should start with the other question. What is PPI? Patient and public involvement. So what both I and Letitia have just been speaking about. But yeah, in terms of Prime, we've got a few PPI, patient and public involvement team members who are going to be working with me to develop all of the recruitment processes for the pool that we're creating, so that we try and make those as accessible as possible, and so that we kind of run the project with that patient experience at its heart from the get-go. So we would love people to keep an eye out for those opportunities to join us in the future, but there isn't a way to register your interest just yet.
Thank you. Letitia, I have a question. Any questions on? She'll come to you now.
Good afternoon. My name is Diana Vieira. I'm a patient, a psychologist, and an academic. So I was diagnosed 3 months ago, and I have been ill for 3 years. And one thing that I thought you were going to talk about, because I was very looking forward to this panel, is as a patient, it's very difficult to find doctors that understand us and so on, and we have been talking about that. But there are other things that I think is most important. That is, what can I do as a person that is ill with this syndrome? And people tell me, oh, do pacing, manage your energy. I say, but how? And I think
we've just lost you online, so we're not hearing the question right now.
So, do you have resources for the patients to understand how can we do pacing? Where are the people that have the similar symptoms as I do? Because I already belong to this Portuguese association, but I can see that people are so different from me that so the support, social support is very important for our health, not only physical, but also mental. So as patients too, I was expecting you to give some guidance. I know this is a medical conference, but without us, they will not be here.
Thank you so much. Sean, do you want to go first? Or?
Go for it, you go.
Yeah, I appreciate that question a lot. I think that is definitely a challenge for all patients to find resources that are evidence-based and are trusted in our community. Internally, we have collaborated with organizations like MEAC, who developed a pacing guide, and so we have developed co-developed with them a pacing guide for clinicians, exactly following this idea that sometimes the clinician is not familiar with patient, and the patient needs to bring that resource that is geared to clinicians. But the resource is also accessible to patients, and ME Action also has this resource specifically for patients. At Patient Led, we are also, this year we have been collaborating with Rhythm to develop a guide of possible pharmacological interventions for people with long COVID, and that encompasses, things like what are the treatment options, right? Because a lot of times we're told that, oh, I really, I have empathy and I understand what you're going through, but there is nothing I can do for you, which is not true. There are options there for symptom management and things that have been used, especially in ME care, for such a long time. And we really need to harness that knowledge and put it out there. So hopefully we will be releasing this resource this year still, and we're also going to be translating it. And the pacing guide is also translated to Portuguese, Spanish, and French.
Brilliant. I think a great answer from Letitia. I think I would add to that prior to my work with Prime, I was working with an organization called the World ME Alliance, and we have recently kind of published a pilot version of an online medical education hub. Now, technically, it's aimed more at health professionals than it is at patients, but I think it also kind of directs patients to some of the best resources that are already available out there, and what resources there are in different languages to speak more about, how to live day to day with this illness, because it's not easy. And yeah, I think there's other resources you can go and find through the World ME Alliance website, including a resource on how to involve people with ME and other energy-limiting chronic illnesses in research. That's a good one. But also, it just directs you to who your national charities are working around this illness, and I think that's a good way to reach out and find that support in your own language, in your own country. And I think you're absolutely right to say that social support is a big part of what is needed for people with ME, especially when there are treatment options, and yet we also still have to live with very significant symptoms with this illness. So it's all part and parcel of trying to do the best we can with our current knowledge levels.
If I might, Malina Marafati unfortunately wasn't able to join us. She was the third panelist today. There was a very important audiencia federal in Brazil yesterday at the federal level to discuss the new fibromyalgia and chronic fatigue law. So she's just overwhelmed. But Malena would have spoken about the focus groups that we've done. Malena coordinates a focus group in Brazil with long-term ME and long COVID patients with over 6,000 patients. And we also have a support group here in Portugal with people that have been living with this illness for 10, 20, 30, and 40 years. So a lot of the experience in terms of where the publication meets the realistic application of these techniques resides in the cumulative experience of these patient activists. And you're welcome to join us. The group is professionally moderated by Malena, who is a former oral maxillofacial surgeon, a highly trained academic clinician, and someone who's been living with ME for 30 years. It's moderated around the clock. It's open 24 hours. It might take you a couple of hours to respond, but a lot of the patients in the group, because of insomnia and because we have Brazilian patients, will chime in 7 days a week, 365 days a year. So we do have that structure in place. And so please join us. So
Can I add one more thing about support groups? I don't know if you can hear me.
Yes, we can.
Oh, okay, good. Yeah, I want to highlight the importance of that. And I think from my personal experience, it has been, especially, I also had a very delayed process of diagnosis, including of ME and of POTS. It took me literally 5 years to get a diagnosis. And in the meantime, I think what has saved me, I say it saved my life, was the knowledge of patients and patients who were in this fight before us, like ME patients especially. So I extend like a lot of gratitude to them. And for folks in the US, if you are in need of a support group, please reach out. There is a Discord support group. It's not moderated by us, it's moderated by a different group of patients, but we can send you an invite. So reaching out and trying to find support groups is definitely something very important.
I just want to add to that, a simple resource you can access is at the Workwell Foundation. That's all one word, workwellfoundation.org. It's in English, but they have very accessible resources about pacing and what is post-exertional malaise. You go to their website. There's some video clips there, but one of the things that that you can begin to use as a guideline for pacing is your resting heart rate plus 15, and try to live under that heart rate until you get a 2-day exercise test where they can tell you more specifically about your heart rate guideline. But if you don't have that, that's fine. Use your resting heart rate plus 15 as a guideline to try to stay under a heart rate that will exacerbate symptoms. I'm speaking tomorrow about the 2-day exercise test, so feel free to pepper with questions at that time too.
I would just add for everyone who's worldwide watching us, look for Facebook, Reddit, Discord groups that are the diseases that you have, and you will find that patients who have it for a long time, they will have resources for you, and they'll share practical, not all necessarily science-based, but they have practical experience, and that, again, we spoke earlier, has value. So we'll find there. There's lots of patients with self-resources, and they will guide you to associations in each country, and they will guide you to doctors that understand the condition. They might not have all the answers, but at least they'll not be dismissive of you. And that is a help because you are in a group and not being dismissed. I have a question from a viewer. Is there a wish list, a priority list of topics that the patient researchers think should be research or research strategy more generally? For one of you or both of you.
I'll start off with this one. So a few years ago in the UK at least, there was a project called the Priority Setting Partnership run by an organisation called the James Lind Alliance. And they've run these partnerships in quite a few other disease areas and were able to do one in ME. I was fortunate enough to be on the steering group for that project. And so through a kind of elongated process, we went out to kind of multiple rounds of survey for people in the UK who either have the disease or are carers for people with the disease or are healthcare professionals working with people with the disease to suggest research topics around the illness, and then to kind of go through a process of voting for which ones were the most important. And we came up with a top 10 plus, because there was actually 11, a top 10 plus research priorities in ME CFS that have been developed by people with ME, carers and healthcare professionals. So you can look for that by searching Priority Setting Partnership ME CFS or psp-me.co.uk. I think it's a really useful resource for directing future research. In the UK, at least, it will be used for, well, if people put in funding bids related to those top 10 priorities, they will be prioritised by some of our major research funders here in the UK. And yeah, it's very much a patient-led project and approach again. So it was a really good one to be involved in. And yeah, recommend go looking up those top 10 ME/CFS priorities.
Thank you. Letitia?
Yeah, I think on the long COVID side, we have been really trying to push forward for clinical trials and investment also in research that can support clinical trials, like development and standardization of outcomes. And I think here we really need to think forward to a scenario where we want to have global clinical trials and we want to have outcomes that can be applied to different populations, different languages, cultural contexts. And right now we don't have that, and there is very little funding that is allocated specific to this work. That is, it's not very glamorous to develop outcomes, but we are in very, very high need of that. And just in general, in terms of just clinical trials for pharmacological interventions specifically. And I think on the side of the pathophysiology, would love to see more research on the pathophysiology of PEM. That's just very needed on all, just an overview of that. And on the structural associations, you know, that we have been developing, like all the connections between CCI and our symptoms and manifestations.
I can, yeah, just add up. I've gone to the website to remind myself what those top priorities are, and there's a huge amount of overlap with what Letitia has just said. So it's good to see that alignment, but very much the priority one is post-exertional malaise and trying to better understand that. And priority two is talking about existing drugs that can be repurposed to treat ME/CFS. And I think, yeah, it's good to hear Letitia talk about kind of those outcome measures. And I know that we want to see clinical trials, but we want to see them done well and in a way that can be replicated and that we can really rely on so that patients get the information that they need.
Thank you. Thank you for your participation. Thank you for all the work you do. And have a rest of a good week. We're going to then break now for a 10-minute, 15-minute coffee break, and then we'll restart in 15 minutes then. Thank you.
Please go. Let's get him.
Bom, boa tarde a todos. Vamos recomeçar os nossos trabalhos com uma conferência pela doutora Linda Tannenbaum. A doutora Linda Tannenbaum é presidente da Open Medicine Foundation e tem dedicado... let me begin again. Founder and CEO, president of the Open Medicine Foundation. As president and CEO of Open Medicine Foundation, her efforts are dedicated to funding and promoting research into ME, CFS, and related chronic complex diseases. Linda created OMF in 2012 with a vision of catalyzing large-scale research efforts to develop diagnostic tools, effective treatments, and ultimately prevention methods for these diseases. Linda, thank you very much for agreeing and talk to us. The floor is yours. Okay.
Good afternoon, and thank you for inviting me to speak today. Especially thank you to Joan Hoffman and her team with Alianca Millions Missing. I'm sorry that I'm not able to be with you in person today, and I had the pleasure of coming last year. But I'm grateful to be part of this and to have you all sharing your information with each other today. Joan asked me to give you an overview of the origins and vision of Open Medicine Foundation, OMF as we call it, and our collaborative model, as well as how we incorporate patient-led science into all that we do. So some of you have heard me talk before, and I apologize for repeating myself. But for those of you that don't know about us, the purpose of me talking with you today is to encourage and inspire researchers and clinicians to share openly and collaborate to accelerate our end goal, which is really getting people better and back to good health. So I'll get right to it. It's both an honor and a privilege to be with you to discuss the critical work that we're all doing to advance this research and to care for patients with these chronic complex diseases, these conditions that we all know affect millions worldwide, including, of course, here in Portugal. My philosophy has always been that together we can make a difference to bring hope and healing to all. And I want to thank the speakers for all that you're doing and for sharing the information that you're sharing today and tomorrow. It's really important. Like many of you and millions with similar stories, my own personal journey with ME/CFS began in 2006, a year that forever altered the course of our family's life. Our vibrant 16-year-old daughter, who was the picture of health, suddenly fell gravely ill. It was the first day of her 11th grade, and I just dropped her off at school at 8 a.m. in the morning. And she was full of excitement and promise. And within about just 20 minutes to 30 minutes, our world was shattered. We were called from the school nurse that something was wrong. And we ended up rushing our daughter to the emergency room, fearing that she was having a heart attack. Her first symptoms was heart pain. Overnight, our daughter was transformed from an active volleyball playing teenager into someone who could barely get out of bed. The simplest tasks like walking or sitting up became insurmountable challenges. My husband, Don, and I embarked on a desperate quest for answers, taking our daughter to 20 different doctors, 3 different neurologists, a cardiologist, rheumatologist, internal medicine, infectious disease doctor, oncologist, pain management, hematologist, gastroenterologist, and countless others, only to be met with confusion and uncertainty. No one knew what was wrong with her. And I emphasize this because all of these doctors, nobody knew what was wrong with her. I mean, from all of these symptoms, nobody could put it all together. Until about 5 months later, and thinking that she was dying of a misdiagnosed brain tumor, UCLA Rheumatology Pediatrics diagnosed our daughter with something called Myalgic encephalomyelitis, but at that time was referred to and called chronic fatigue syndrome, now called ME/CFS or ME or CFS-ME, depending on where you're from. We were met with the sobering reality, though, that there were no available treatments or solutions for her condition. The only option at that time was pain management, which nothing worked for pain. Even today, however, it can take months or even years for people to get a diagnosis, if you're lucky enough to even get one. The same thing is happening with those who are suffering from long COVID. So many people are not believed and stigmatized and feel invisible and really disappear from life. Many times their own family and friends don't even believe them. This deeply personal experience became the catalyst for me creating Open Medicine Foundation. Once I found out that millions of people have this disease, millions of kids are out of school, millions of people are out of work and home, and not enough was being done about it at all, anywhere in the world at the time. Someone needed to do something to find a way to diagnose and treat these horrific diseases and then train clinicians to recognize them so people didn't have to go to 20 different doctors and then get no diagnosis that is going to lead to a treatment. Despite the urgent need, government-funded research, as you know, for ME/CFS is minimal worldwide, lagging far behind most, if not all, other diseases. Because of this, research is mostly funded by patients and loved ones themselves, donating to nonprofits like ours and others in this space. And this, of course, slows the progress tremendously. I'm going to share my slides. I have a few of them. Hopefully you can see them properly. In response to this urgent issue, we established OMF in 2012, and this is now our 13th year. And I thought it was important to give you our purpose, mission, and vision so that way you can create something yourselves along the way so that all of us can collaborate worldwide. Our purpose as we set up is to revolutionize the way we understand and treat chronic complex multi-system diseases that are really not looked at as a whole, with the initial focus for us with ME/CFS and Long COVID, by illuminating their mechanisms, accelerating effective treatments, and empowering personalized care. Our mission is to drive and fund global collaborative research that unlocks the disease biology, delivers precise diagnostics, and advances treatments, giving every patient a pathway to care and hope. And our vision, all of our vision, is a world where ME/CFS and Long COVID and those related diseases are understood, rapidly diagnosed, and effectively treated, so every patient can live fully. OMF is distinguished by an international collaboration. We have an international network, which is essential to accelerate transformative results. Our research directors include and mentor many young investigators on their research teams with over 200 scientists and clinicians on their combined teams and collaborators. We built an expansive research network that spans 3 continents, connecting leading scientists from Uppsala, Sweden, Stanford and Harvard University, and the University of Melbourne in Australia and Montreal in Canada. And we collaborate with many other research centers across Europe and Australia. We hope to do the same with Portugal as well. These partnerships work because they're built on trust and shared principles, scientific rigor, open collaboration, open communication, and an unwavering commitment to patients. The collaborative model includes several key elements. Samples collected can be shared to maximize the value of these precious patient samples from center to center. We may collect samples in Montreal and send them to Uppsala, send them to Australia, send them to Harvard or Stanford. On the same patient samples, we can learn so much. Knowledge gained from one center immediately benefits the studies of other centers, which in turn informs the researchers to either stay on course or change course completely. We have monthly meetings with our directors and an in-person meeting once a year. Regular international conferences like this one facilitate knowledge exchange and a culture of openness where researchers share both successes and we want to hear your failures, accelerating and learning for everyone. To date, we have supported over 67 different research projects and many publications through our centers and have inspired and collaborated with many other researchers, setting a global model for others to emulate. We're just trying to accelerate research. This is why Joan asked me to speak with you today. This is why we're all here, to encourage open global collaboration. In addition to our focus on medical education, we have 3 research pillars that our research focuses on specifically. The clear disease model, accurate diagnosis, effective treatments. How can we translate to improving patients' lives? We and other organizations like Aliança, Millions Missing, shape research priorities by listening, truly listening to patients and their families. We hear their stories, understand their daily struggles, and translate their urgent needs into research questions that we discuss and pursue with scientists. This patient-driven approach ensures that research efforts translate to improve patients' outcomes. We have people with lived experience on our boards and on our staff. We've learned that the people with lived experience must be partners, not just subjects in research. They're essential to all aspects of study design, from priorities, criteria, outcome measures, subsets to consider, and the protocols themselves. The patient community has been instrumental in shaping our research agenda. People with lived experience teach us which symptoms matter most, which outcome measures truly reflect their experience, and which research questions will have the greatest impact on their daily lives. We still have a lot of improvement needed in this area ourselves, and we want to increase the engagement from those who know the most about these diseases, those with the lived experience. We published a paper that Dr. Wenzong Zhao spoke of during the last conference here, from patients reporting which treatments worked for them, what symptoms they helped, and which ones harmed them. After almost 2 years of analysis, we were able to share this with the public. And also, we took this information and altered our own clinical trial outcome measures by what we learned from those experiencing these diseases. Dr. Martha Ecke, a person who sadly is living with these diseases, created this incredibly detailed survey to gather this information from others like herself that are living with ME/CFS and Long COVID to help others help themselves. One challenge that most researchers have is finding enough participants. Therefore, in May of 2023, we launched OMF's StudyMe participant registry, a groundbreaking initiative designed to bring those interested in participating in research to those researchers looking for participants, therefore accelerating recruitment and in turn accelerates research. OMF Registry empowers individuals with ME/CFS and Long COVID to actively participate in research, with over 14,300 participants already, growing rapidly from over 61 countries. OMF StudyMe has already facilitated recruitment for over 20 research studies at top universities worldwide. It's free to patients and it's free to researchers. The purpose is to simply accelerate research. Last week, we heard that we had gone out with a request via StudyMe, and the researchers received 500 signups within 3 days of posting their survey. We're here to help. We can share this more in Portugal and invite patients to sign up and researchers, and then help recruiting locally here. We have a large 1,000-sample biomarker discovery project just about to launch in Sweden, with samples from patients in Sweden and 5 clinicians across the US via the National Institute of Health biobanks, with testing done in Canada, Finland, and Uppsala. We also have a project that we're calling, and it's called BioQuest, large-scale, geographically diverse, disease-controlled biomarker signature discovery project. We're looking for a biomarker signature. We've acquired about 1,000 plasma samples already, 400 ME/CFS, 200 healthy, and 200 disease controls, including Long COVID. The testing will be involved with multiomics, cytokines, immunoassays, and expected to begin by the end of the year. We're very excited about this project and where it may lead to. The other big project that we're doing is the life improvement trial, which we call the LIFT, and it's a randomized double placebo-controlled clinical trial on low-dose naltrexone, LDN, and pyridostigmine mestinone. And we have about 160 participants that we are anticipating being as part of this. About a third of these total participants have either completed the trial or are in progress at this time. Perhaps most importantly, research is providing hope. For too long, patients with these conditions have been told that nothing can be done. Findings are challenging and showing us the narrative that these are real biological diseases with identifiable mechanisms that can be targeted with appropriate treatments and possibly reverse this disease altogether and bring people back to good health. Portugal has tremendous potential to contribute to and benefit from global research efforts in this field. Your country has several key advantages: a strong healthcare system with excellent medical professionals, world-class research institutions with infrastructure to conduct cutting-edge studies, and a strategic location that facilitates collaboration with both European and international partners. And most importantly, a patient population that would benefit enormously from advances in this field. Portuguese researchers could contribute unique perspectives to global studies. Your researchers' expertise in areas like immunology and neurology and infectious diseases could provide crucial insights into disease mechanisms. Collaborative studies need diverse patient populations to ensure that findings apply broadly. Portuguese patients could contribute to biobanks, participate in clinical trials, and help validate research findings across different populations. Portugal could also serve as a model for how smaller countries can punch above their weight in global research efforts. By focusing on specific areas of your expertise, building strategic partnerships, and leveraging existing strengths, Portuguese researchers could make a disproportionately large contribution to this field. The challenges we face are significant, so is our potential for impact. These diseases affect millions of people worldwide. We all know that. But they also represent an opportunity to demonstrate how collaborative, patient-centered research can really transform lives. Success will require continued investment in research infrastructure, support for international collaboration, and most importantly, a commitment to keeping patient needs at the center of everything we do. It'll require countries like Portugal to see themselves not as peripheral players, but as essential contributors to the global effort. The urgency is real, but so is our determination. With continued collaboration, sustained investment, and unwavering focus on patient needs, we will transform the landscape of care for these complex diseases. Looking forward to where we stood in 2012, and now with a perspective of 2025 in the next 5 years, OMF's roadmap is clear. We're moving from pure discovery science towards translating research findings into diagnostics and targeted treatments. We've been doing this for 13 years, it's time. The integration of multi-omics data across our global network is revealing patterns that point towards personalized treatment approaches. Over the next 5 years, we envision a world where ME/CFS and Long COVID patients can receive objective diagnostic tests, where treatment decisions are guided by biological subtyping rather than trial and error, and where targeted therapies are based on mechanistic understanding. This isn't wishful thinking. It's a realistic projection based on the trajectory of the research project progress and the strength of everyone's collaborative effort worldwide. Open Medicine Foundation exists and thrives because patients around the world continue to advocate, participate in research, and support scientific progress. It's succeeding because scientists are willing to collaborate openly, like yourselves, share data freely, and mentor the next generation. And together, the world at large will ultimately achieve this goal of finding effective treatments and ultimately cures for ME/CFS and Long COVID and these related conditions, because we recognize that patient-led science isn't just a philosophy, it's the fastest way to break through discoveries. Thank you all for being part of this journey, and together we can make a difference. Thank you so much.
Bom, não podemos fazer perguntas, não é? Portanto, questões. Portanto, passamos imediato. We won't be able to do any questions, obviously, so we'll go forward to the last of our sessions of today, which is a panel discussion, which title is Strengthening International Cooperation in ME/CFS and Long COVID. I will be moderating this last session, and I'm going to invite now the two participants. First of all, Michael Baum is a member of the executive board of the Foundation for Luso-American Foundation here in Lisbon, and professor at the Catholic University of Portugal. At the foundation, he oversees education in science and technology portfolios, including oversight of the Study in Portugal Network Study Abroad program. His work serves to build and strengthen institutional partnerships between Portugal and the US, particularly in higher education and between the academy and civil society. So, Michael, would you mind to join us? Thank you. The other participant is Emily Taylor. She is the CEO of Solve.ME, has over 2 decades of experience in health policy, grassroots advocacy, and community empowerment. Right. She has been instrumental in advancing research and amplifying patient voices for ME/CFS, Long COVID, and other infection-associated chronic conditions and illnesses. Emily? Okay. Hello, Emily.
Hello, I can hear you loud and clear.
Can you see us?
Yes, I can.
Okay, we can also see you and hear you, so that's perfect.
Merci.
Now, the title of this small roundtable is Strengthening International Cooperation in ME, CFS, and Long COVID. So my first question goes to, let's do it this way. I'll ask a question to both of them, and then we open for the audience to ask stuff. Is that okay with you guys? Merci. So I'm gonna ask Mike, no, I'm not Mike, first Emily. Emily, I would like just, oh, she's not there. I'm just like to ask you, given your experience as an activist in this disease and this type of pathologies, and given the fact that in so doing you are contacting a lot of institutions, a lot of people, a lot of patients, a lot of researchers, what would be your suggestion to precisely strengthen the international collaboration to achieve the goals of, first of all, treat, second of all, cure, and third of all, prevent this disease? And once again, thank you very much for being here with us.
Of course, and thank you so much for having me. I wish I could be there with you all in person. Unfortunately, my mother's caregiving schedule required me to be back here at home. As you know, my mother is a person with this illness, so I come to this disease space with a deep empathy and understanding of what it means to both talk about the lived experience of our loved ones and try to marry that with the science and the immense flywheel of understanding that we've developed, especially in the last few years with long COVID. So I really, and I don't mean to sound flippant, but I really bring it back to the values of our organization, which are science-driven and patient-first. And that's really the values that I bring to this work. And so I think it's a partnership of real stories with real patients that show real suffering. And I can speak to that with my mother's experience. We have, as you know, our Advocacy Week specializes in bringing patients themselves to the member of Congress to show that story directly, and then preparing those folks with real data and important data that can tell the story in the big context of the large impact internationally. And that's where I really think our international collaboration can come, is that element of data sharing and showing that this is a global issue. You know, COVID was a global issue. This did not hit just one country or one party. So I think really it's what unites us in fighting these illnesses that brings the strength together. And that's what I try to focus on when in my messaging is how this is something that touches all humanity, and it both through the economic lens, through the social lens, through the clinical lens, that all aspects of our society have been impacted by this in some way. And that is the message I try to bring when I, as you say, conduct advocacy and activism to get more research funding into the field.
Okay. Thank you. Michael, as a representative of one of the most important foundations here in Portugal, one that was set up many, many years ago precisely to increase the connection with the US, and has been doing so in a very, very, very efficient way. It's a really prestigious institution. And of course, one of the areas that the foundation does is actually sponsor and finance a whole bunch of research projects. So I'd like to hear you in terms of what you see as not only the role of the FLAB, but also the role of some foundations like this one in fostering the research and support missions.
Thanks, Antonio and Joan. Nice. This is a great conference. I'm learning a lot, and not at all an expert on this disease and diagnosis. So thank you for organizing this. I'm glad that FLAB could help support some of the folks who are coming here to speak to you about their work. So let me just say a couple words about FLAB first. And it's fairly well known in Portugal, but I think in the United States, we're fairly unknown. We're a private Portuguese foundation that, it sort of works in the orbit of the two national governments, but we're really, very much a private foundation that does our own thing. And that's, I think, what Antonio was referring to. It means that we can work pretty efficiently and quickly to make decisions. We don't have to go through the public procurement process. In terms of what FLAD does, we essentially help to build bridges between the US and Portugal in science, in the arts, in education, in transatlantic relations. I was just speaking earlier today with one of the participants here who received a grant as a journalist to go to the United States back in 1997. We were talking about how that changed him. And so, you know, basically it's the greatest job in the world. We get to give money to people who have interesting ideas and want to do something, you know, either in Portugal as an American who's interested in Portugal, or somebody from Portugal who wants to do some research. I'm just going to give you a quick, you know, and this is not exhaustive. You can go to our website. It's both in English and in Portuguese. So it's flad.pt. If you want it in English, just add an asterisk and EN. Anyway, so we have programs that do things like, one of them is R&D at USA, and this is for young researchers, masters, PhD level, or recently, you know, doctored, let's say postdocs, who want to do a 4 to 6 month internship in the States, in their field. These typically last for 4 to 6 months. We also have, I noticed there are several Americans here, researchers. If you are invited back to give a talk in Portugal, we have something called US at PT that allows you to get some funding for your travel and stay here for, you know, giving us these kinds of talks, basically. We also have USA at PT, which is, these are funds that go to Portuguese institutions to help bring Americans from the US. We have various awards. I'm not going to discuss all of them. But, you know, essentially what we do is we help to build bridges. And we're fairly unique in the sense that geographically, we're very circumspect. We only do US, Portugal. But within that, we fund all kinds of different things. And this conference is a good example of that. As for the role of private philanthropy, I mean, I think one of the things that, at least I'm working hard at FLAD, and I think our relatively new president feels similarly. A lot of times in Portugal, it's easy to kind of fall into your silo and you just do your own thing. One of the things I'm hearing from this conference is the importance of collaboration. And that's very much kind of a spirit that at least our administration at FLAD is very keen on. So we've been making several inroads to Gulbenkian, to Champalimod and other foundations. You know, typically we kind of have our backs turned to each other. But I'll give you one example. We were approached by ASPIC, which is the Portuguese Center for Investigation in Cancer Research. And they had an idea that would essentially take young Portuguese researchers to the States, much in the same way that I just described to you, for an existing program that we have. But this one would be specifically focused on cancer. And this is working, you know, with the top cancer research labs in the United States. And so we gave them a grant to help take young researchers to spend some time in labs in the United States to build networks, eventually maybe engage in co-production of academic research. And this was through the Gulbenkian Science Institute, with Champalimod, with ASPIC. You know, we're all kind of working in collaboration. And so from what I'm hearing about this particular disease, it sounds like that's going to be absolutely fundamental for this to make progress. And I would just say, you know, think of FLAD, because this is what we do.
Thank you, Martin, Michael. Oh, and thank you for support this. I'm sorry. I raised the question of foundations because here in Portugal, we are just starting to change this landscape. And there are now much more foundations, private foundations, that actually do an active philanthropy. And so we feel that science is one of the areas that we should do things, and certainly in science, certainly in medicine and health, but there are other examples. So this would be also a way of looking at our society, which is different. I recall a very wealthy businessman that just recently, about a year ago, inaugurated the most astonishing museum of modern art that I ever saw in my life, with really an extraordinary place. So if we have these examples for arts, which is something that the foundation does, we should also try to get this to science, which is somewhat easier. It is somewhat easier to get the foundations for science than it is for arts. But we believe that public fund is important, but we shouldn't just be waiting for the public fund. We think that we should take the lead and try to find people that have, that are basically wealthy, and that can be actually support this kind of initiatives. Whether they mean or that's a different thing. So now I will pass to you guys the microphones to put a question either to Emily or to Michael. Thank you. It's a long day, so.
Good afternoon.
Please.
Just how do people approach you for grants? Do you have a specific time of the year? It's continuous. So how do they approach you and where do they go?
Should I take first crack at this? So can you guys hear me okay? Yeah. On our website, you can see there are certain grant calls that we have that are time delimited. For example, we have, for those of you who are based in universities, we have a €100,000 per year award for internationalization of Portuguese universities toward the United States. And so this grant call is open for 3 months, from May until September. Other grants we have, for example, essentially the mobility grants for Portuguese to go to the States or vice versa. They're on a rolling application basis. So if, let's say, your conference is going to be in April of 26, you might need to have your request into us. It's all on our website. I don't have it all memorized, but let's say it's about 3 or 4 months before the conference. And even if you haven't been formally notified that your paper has been accepted yet, but you've already applied, you can still submit your application to us by the deadline date and say, I'm still waiting for notification. And then once you get your notification, we write the check, And so it's the nice thing about it is it's a fairly flexible foundation. We get lots of what we call ad hoc requests. So, this is just somebody writing an email to us and saying, here's my idea. Is this something you're interested in? I can tell you internally, the way this usually works is whether it comes in, say, through me or maybe someone who works with me, it'll make its way to the person who's in charge of that portfolio at FLAD. Typically, they kind of give an initial, this looks worth exploring. And then they give it to one of the operational people on my staff or whatever portfolio we're talking about. And they do an initial sort of analysis. And then that request comes to the executive board. Right now, it's just myself and the president, but typically we're 3. And the executive board makes the decision, and typically you'll get an answer fairly quickly. So it's a pretty flexible foundation.
Yeah, John.
I'd love to jump in on that question quickly as well. SolveME has 3 grant programs available to international participants and US participants as well. I'll go in order from largest to smallest. Our largest is our Catalyst Award program, which are one-time awards that are for research projects, direct costs. Those are available by invitation to participate for submitting an application only. Our open access program is our Ramsey Award program that is currently undergoing a revision, but when it is relaunched, will be a rolling application cycle, and that really focuses on early career researchers with the focus of allowing you, the researcher, to create pilot data with those funds that you can go on to submit to other grants for follow-on purposes. And the third program, the smallest, is our Micro Grant Award program, which is overseen by our Lived Experience Task Force. This is our most flexible program. Everything from educational programs to travel awards. This is really at the discretion of our Lived Experience Task Force. And so that's an opportunity for very small one-time payments that can be used for a variety of purposes. So that's the different opportunities we have, and all those opportunities are open to international participants.
Thank you, Emily. John?
So I had actually 2 questions. One was for Emily. Michael Baum described how Portuguese foundations are starting to work or network together to address complex issues that require working across silos. And my question was, are there comparable movements in the US? And then The second question was for Michael. Given that you're doing this work and you're working across silos, and we know that there are recognized centers of excellence in the United States, is there any thoughts about potentially including U.S. foundations, Open Medicine, DecodeME, in that? So that's a two-part.
Emily, go ahead. Emily, you wanted to go first?
No problem. That is a great question, and I wish I could point to more examples of this type of collaboration in the United States. I think we are recognizing the important need for all of our different organizations, nonprofit actors, for-profit actors, businesses, NIH and government partners to really come together in a cohesive whole on this, because the resources are so scarce and there's no room for duplicating efforts or leaving gaps. So it's too important, and we're working on such tight budgets that we really need to collaborate in order to move this field forward with all of the different opportunities there are. So the one opportunity or the one success story I will point to in this area that I think I find is a point of pride here in the United States is the NIH ME/CFS roadmap. This project was a fantastic collaboration to really bring that spectrum of different stakeholders to the field to have those conversations. And I really stand by the direction and prioritization of research that is shown in the NIH roadmap for ME/CFS, because if and when, let's think positively, when that research plan is funded, I see that as a real comprehensive mechanism moving forward to create that synergy. And then the last thing I'll add, and this is something that's very close to my heart personally, and I feel a very deep connection to this area, is data sharing. I think that that's going to be so critical, and data doesn't have a language, and especially in the ME/CFS space, we can bring our data together through projects like the Solve Together platform, the Unhide platform with the Brain Inflammation Collaborative, start using these big data sets to bring our small sample sizes together, but then replicate in other cohorts. And for those of you who may remember Dr. Sadie Whitaker, one of our former chief scientific officer, she often talked about the big data dream for ME/CFS. And I see that big data dream as international. I see that the US has to be a part of it, but the sooner we can get the mechanisms and systems and in place that allow us to share our data, so that we're looking at all of the different opportunities and results that are coming from different researchers to replicate, to accelerate, to catalyze. I think that's really where we're going to see some big results in the future if we can get our data sharing up to a good functional level where we can bring that data across different borders.
And yeah, Joan, great question. The short answer is yes. In the past, we've collaborated with NSF, for example. You know, I would just, I guess, a little bit of context. You know, we're a private Portuguese foundation whose mission is to, through the bilateral relations with the United States, promote the development of Portugal. And so I would say, for example, because of just the imbalance in terms of access to capital and resources that the United States has in comparison to Portugal, most of our grant funding tends to really focus on the Portuguese side. So for example, on that grant that I mentioned for educational internationalization, the call goes out to Portuguese universities. They're required to have a US partner as part of their proposal, but the money goes to the Portuguese universities. Recently, we also, I had a long list of projects that we fund, but one that might, again, be of interest here. We just did a webinar, I don't know, 3 days ago, to researchers in Portugal and institutions. Vlad, for, I don't know, more than 20 years, we've had a long relationship with UC Berkeley. And recently we kind of, I would say, deepened that relationship by partnering with the National Science Foundation here in Portugal. And so FCT. And so FCT is now putting in money, Vlad is putting in money, and this is helping to, I would say, cement a private fund that exists at UC Berkeley, a couple $1 million to fund building links between Portugal and the US. So even though it's not a foundation, UC Berkeley being generally regarded one of the top public universities in the United States, So again, for Portuguese-based researchers who would like to do a stay at UC Berkeley, it also funds researchers from UC Berkeley to come to Portugal. It can also fund students, and that just happens to be one that popped into my brain. But there's I would say, total openness on our part to collaborating and leveraging our funding with other institutions who want to row in the same direction. Yeah.
Thanks, Michael. Another question, please? Comments? Great. So if there are not any comments or any questions, we will close for the day. Thank you very much for your stamina in staying here all day long. It has been a pleasure. And you'll see you tomorrow at 9 o'clock. So thank you very much. Once more.
Penso.